This is the virtual workshop of the Smart Africa Network, and we will be having a session for throughout the day. And I just want to say that individuals can hop in and jump in or jump out as we progress. But we're looking to have an exciting session this morning and throughout this afternoon. So if you look at the lineup, we're going to go in to have the first session, which is going to be just in about 10-15 minutes, and we'll look at the fundamentals of principles of MRI. That will be taken by Mariana Salifu, and then we'll go to MRI anatomy. Then we'll move to basic techniques, and then we'll have a short break, and then we'll go on to have, talk about how you can build your own low-field MRI scanner. This is going to be taken by Serum Gainhardt, and we'll then move out to talk about MRI safety and then understanding MRI equipment installation. And then we'll have another break, and then we'll go on to talk about precision health and imaging in the age of artificial intelligence. I'm sure most people are looking forward to having that. And then, of course, we'll have a closing remark by our president, who is the president of the African chapter of the International Society of Magnetic Resonance Imaging. So let me just give you a brief intro and background about what Smart Africa is. So I will take you through what Smart Africa is. Smart Africa is actually strengthening MRI access, research, and training in Africa. And we organize training workshops around Africa. And basically, we started becoming active in 2022. And this is basically a coalition of African MRI specialists. And we work with global partners to promote MRI utility in Africa. The aim of the Smart Africa Network is to strengthen partnerships with global organizations, global partners, manage MRI training programs for Africa, and also to help achieve improved MRI utility in Africa. We also try to retain and retrain MRI specialists and upskill MRI specialists, either radiologists, biomedical engineers, or radiographers and medical physicists in the continent to upskill their capacity in the use of MRI. And also, we hope to be able to ensure that we can transfer AI and data science skills to African researchers. These are our aims. We held the first meeting, which we had was in Uganda in 2022. This meeting brought together all specialists from various parts of Africa, and we're able to collaborate, with Leiden University in the Netherlands. And that afforded African scientists to see for the first time an MRI, low-field MRI scanner being assembled in Uganda. And this was a very unique opportunity to see, and that's a low-field scanner. This is a prototype of a low-field scanner that can be used for brain imaging and things, and it was first assembled in Africa and Uganda, and Smart Africa was part of that collaboration. Also, we brought together, of course, a lot of specialists, neurosurgeons, and all that to discuss at the Mbarara University. This was a very unique collaboration that had building a low-field MRI within 11 days to show that these things are still possible. And we're hoping that we can go on to do similar things across African countries and even in Nigeria. So I would also like to just give you a short video which I've played, but I want people to just have a sense of the things we have done, and that is best. A picture speaks 1,000 words. So just watch this 2-minute video, and then we'll move on. All right. So this was the meeting we held in Accra, Ghana. And that was the second meeting. That was the first, of course, ISMRM African chapter meeting that was held in Ghana, and the second Smart Africa workshop. The next one was held, the third, Smart Africa workshop was held in Tanzania. And you can just take a listen.
Every regional hospital in Tanzania is equipped with a 64-slice CT scan.
All right. So that was our meeting in Tanzania. And just to give you a brief, what's going to happen in Lagos in next week. So this our virtual meeting is just a pre, insight into what we are going to be doing next week. So just to give you an insight, the second workshop we had, which was in Ghana, we brought people, and this attracted several people. We had over 200 registrations from about 14 countries, and we had attendees from about 14 countries. To let you also know that our focus is basically radiologists, radiographers, biomedical engineers, and medical physicists. The meeting also sometimes help to look for, because with the support we received from the Chan Zuckerberg Initiative, allowed us to sponsor travel grants. And we have done this a couple of times. And the first travel grant was in 2023. We had about 9 people who had travel grants. And we are hoping that these meetings will continue. We'll be able to get funding to also sponsor people across Africa as well. So this is just an overview, just giving you a snapshot of the meeting in Ghana to see the spectrum of people wearing different, of course, attires, representing their different specialties. The third workshop, Smart Africa workshop, was in Tanzania, and the workshop registration was over 200, and we had people from about 17 countries. And this is just a snapshot to show you the pictures of the Tanzania meeting. And just to say that our workshop, the Smart Africa workshop, is usually done in conjunction with the ISMRM African chapter. Is used as the pre-conference workshop. And this year, we're going to have a separate workshop from the ISMRM conference because of logistic reasons. But we usually have our meetings with the ISMRM African chapter conference. So this is just show you the workshop to know what you are to expect in the coming week, where we'll start the full workshop. Okay, and these are some of the awardees that we had in Tanzania, and then some of our speakers. So we also do support research. We also give out some grants, and we have also awarded some grants, and one of them is hosted in Lasut. We also give travel awards. This year, we have got a few travel awards that will be for people who coming from other African countries to visit Lagos. One of the awardees for our grant is in Lasut, and we also have one of the radiographers that was given a travel award to the Tanzanian meeting. So this year's conference is going to be, or this year's workshop is going to be in Lasut, which is going to be from July the 23rd to the 25th. So I'm sure most people have already registered. So I can tell you that you are in for a wonderful time. So the fourth Smart Africa workshop will hold in just 1 week. and I'm looking forward to an exciting time. The major highlight is that we're going to have a pre-workshop boot camp, which is going to be held at the Redeemers Health Village. This is a purely invites-only meeting. So for those people who have been partners with Smart Africa Network, will be invited for this meeting. We have several top speakers, both for the pre-workshop and then for the main workshop holding in Lasot. So you can see some of them here. We're going to have hands-on demos and things like that. Well, how can you support us? One of the ways people can support Smart Africa Network is to allow us to use their MRI centers for practical sessions and also to provide either teaching auditoriums for us to be able to use to do our MRI teachings. And also, if you can recommend people who are vast in MRI to join, the Smart Africa Network so that they can be instructors and help teach other people. The key thing is to be able to build a network where there is transfer of knowledge. So we are encouraging people to join the Smart Africa Network. We have a website, which I'm sure most of you might be familiar with. There is no fees, there's no subscription to join the network. But I can assure you that joining will improve your skill, will improve your knowledge, will grant you access for mentoring and for research across Africa. So just to let you know that there's an ISMRM conference, which is the International Society of Magnetic Resonance meeting as an African chapter, and that meeting will be taking place in Tunisia on September 26th to 27th. But the Smart African Network will also be hosting another workshop in Cape Town. This meeting will be held along with the international conference, which is coming to Africa for the first time. And we are going to organize research collaborations, teaching sessions, and exchange program. So I'm looking forward to that next year. So just to acknowledge all the people that have supported us and to tell you that for you that are joining these virtual sessions, you are in for a wonderful time. I want to just take this few minutes to say, take your time and enjoy the meeting. Hop in and hop out if you can, but don't miss out on these beautiful lectures. So you're welcome to the virtual series of the 4th Smart Africa workshop. Thank you very much. So we can jump into our lecture. Thank you very much. I think Shola will be coordinating the next series of meetings. So I encourage you to participate, learn, ask questions, because it's going to be an interactive session. Thank you very much. Shola, you can take over.
Thank you everyone for joining once again. Like seen in the itinerary shared, the program for today, we're starting with fundamentals fundamental principles of MRI by Dr. Miriam Salifu. Dr. Miriam Salifu, she's a PhD graduate from Michigan University, and she's into development of new protocols and advancing MRI techniques through AI. Dr. Miriam Salifu has been with us, has participated physically in our previous workshops in Ghana. She has been part of our network since 2022, and she has contributed so much to Smart Africa. She was working recently with Professor Douglas Knorr, who was into functional MRI in his laboratory at University of Michigan. Our research interests include MRI acquisition techniques, pulse sequences, MRI hardware artifact correction, developing physiological noise correction methods for oscillating steady state MRI. Please join me as I share a video. Should we join to answer questions shortly?
Okay, we're waiting for the speaker to launch.
Then I will talk about how I have applied some AI or machine learning principles to my fMRI research. Then I'll finalize by talking about how you can also embark on your AI journey. Let's start with the definition of artificial intelligence. So what is AI? AI are machines that can perform tasks that would normally require human intelligence, such as understanding natural language, recognizing patterns, solving complex problems, and so on. So the ultimate goal of AI is to create machines that can mimic human intelligence. Now on to machine learning. So machine learning is a subset of AI that involves the practice of using algorithms to parse data, learn from it, and make informed decisions based on what it has learned. And deep learning is also a subset of machine learning, and it uses mathematical models called artificial neural network to give AI machines the ability to learn more like humans. So now that we have a basic understanding of AI, machine learning, and deep learning, let's explore how they can be used to address some MRI challenges. So for example, in image acquisition, now we see many MRI vendors use AI to optimize the image acquisition and reconstruction process, significantly reducing scan times and improving the patient experience. For example, G Healthcare's Ericon DL, shown on this slide, improves image quality and cuts acquisition times by up to 50%. AI is also being used to automatically segment different tissues in MRI scans, such as the brain, heart, or liver. This helps in identifying regions of interest like tumors with high precision. AI-based segmentation tool can also help to reduce the time radiologists spend in manually outlining these regions, making the process faster and more consistent. AI algorithms can also be used in assisting with identification and classification of tumors from MRI images, enabling more accurate diagnosis of conditions such as brain and breast cancers. So by using pattern recognition, AI can detect even subtle abnormalities that might be missed by the human eye. Now that we have explored how AI is being applied in MRI to improve processes like image reconstruction, let's take a closer look at the technology that powers these advancements, which is machine learning. Machine learning operates using a simple yet effective structure, which is the input, model, and output framework. The input refers to the input we feed into the system. This could be anything from MRI scans to patient information. The model is the algorithm that learns from this data by identifying patterns and relationships within it. This is the learning part of machine learning, where the model adapts and improves based on the input it receives. The output is what the model produces after processing the input, which could be a prediction, classification, or another result that helps in decision making. So this framework allows machine learning to process and analyze large amounts of MRI data efficiently and with reasonable accuracy. Its ability to learn and adapt over time makes it a promising tool for MRI. Now let's break down the key steps in the machine learning process, focusing on how we might use it to classify a tumor from MRI scans. So first is data collection. First, we gather the data that are essential for solving the problem. In this case, the MRI scans showing different, for example, showing different tumor types along with patient information or other relevant data sets. The quality and diversity of the data is crucial to ensure the model can generalize well. So after data collection is data processing. After collecting the data, it's important to clean and prepare it. This step involves removing noise, handling missing values, and making sure that the data is in a format the model can understand. For MRI, this might mean filtering out incomplete or low quality scans and normalizing the data to ensure consistency. The third step is model selection. Here we choose the appropriate machine learning model. Since we are working with medical images, models like convolutional neural networks could be a good fit because they excel at image classification. The type of model we choose will depend on the problem's complexity and the data we are working with. So the first step is training and evaluation. With the model selected, we move on to training. During this stage, the model learns to recognize patterns in the MRI data, such as distinguishing between benign and malignant tumors. After training, we then test the model's performance on a separate data set to see how it can generalize, to see how well it can generalize to new unseen images. The final step is a prediction. So once the model is trained and validated, it's ready to make predictions on new and unseen data. This is where the model can be applied in a real-world scenario, such as classifying a tumor from an MRI scan to assist doctors in making an informed diagnosis. So now that we have covered the basics of machine learning, let's dive into one of its most powerful models, that is the artificial neural network, or ANN. ANNs are loosely inspired by the human brain. On the left side, we have a simple diagram of a brain neuron. Just like how neurons in our brain receive signals through dendrites, artificial neurons, also called perceptrons here, also taking inputs from the environment. Each input labeled X0, X1, and so on gets weight attached to it. Think of this weight as deciding how important each input is. So just like how synapses in our brain make some signals stronger than others, so once all the inputs are weighted, they are summed together, and a bias is added. The sum then passes through an activation function here, which acts as a decision gate. The activation function helps to determine whether the neuron should fire and produce an output. In simple terms, ANNs mimic how our brain processes information by taking in inputs, weighing them, and deciding what the output should be. So now that we have a general understanding of how artificial neural networks work, let's break them down and take a closer look at their core components, starting with the inputs here. So the input is simply the data that we provide to the network. In the context of our MRI discussion, this will typically be an MRI image. So each image is made up of pixels, and each pixel has a value that describes its intensity. These pixel values act as a specific input into the neural network. So as these inputs pass through the neural network, the model learns from the data and processes it to produce meaningful output. For MRI tasks, this could mean performing image segmentation, identifying diseases, or recognizing patterns. That's why the quality and relevance of the input data are so critical, because they directly impact the accuracy and the reliability of our model's results. So now that we understand how data enters our neural network as inputs, let's move on to discuss the next key component, which is the weights and biases, which are critical in shaping how the network learns. So in a neural network, weights function similarly to the strength of connections between neurons in our brain. They determine how much influence each input has on the final output. So for each input, So for each input, there is a corresponding weight, which is essentially a number that the network adjusts during training. So as the model learns, it tweaks these ways to optimize. For better accuracy. And then we have the biases, which are additional parameters that shape the activation function, which we'll talk about in the next slide. It shapes the activation function, helping the model better fit the data. Just like weights, biases are adjusted during the training to improve the model's ability to learn patterns in the data. So the biases allow the network to be more flexible in its decision making, and together the weights and biases help to fine-tune the network, making it adaptive and capable of learning over time. Now, let's talk about the activation function, which is a crucial part of how neural networks make decisions. So once we have the weighted inputs and the bias combined, the result is passed through an activation function. So you can think of the activation function as a decision maker in the network. The job of the activation function is to introduce nonlinearity into the model. So this is important because without nonlinearity, the model would just behave like a linear function, which limits its ability to learn from complex data. In simpler terms, the activation function helps the network understand more complex patterns and the relationships within the data. So in this slide, we'll look at how training works in an artificial neural network. So this process is crucial because it's how the model learns from the data. So here's what happens during training. First, we feed the inputs, which in our case could be an MRI image or other relevant data. So we feed the input to the network, and each input is multiplied by its respective weight to determine its influence on the output data. The weighted inputs are then summed. Up, and the bias is added, and the results passes through the activation function, which we discussed earlier, to produce a predicted output. Now comes the important part. So the predicted output is compared to the actual output. For instance, if we are using the network to classify a tumor as benign or malignant, the predicted classification will be compared with the true label, that is whether it's actually benign or malignant. So the difference in the predicted and the actual output is measured using what we call the loss function. So this tells us how far off the network's prediction is from the true result. So if the loss is significantly high, it means the model isn't performing well and it needs to be improved. So now that we have discussed how a neural network makes a prediction, let's talk about how it learns from its mistakes, which is where backpropagation comes in. So the goal of backpropagation is to reduce the loss by adjusting the network's weights and biases. So this is how it works. So the model first calculates the error or loss between the predicted outputs and the actual output, and then it sends this error backward through the network, adjusting the weights and biases in each layer to minimize this loss. So this process helps the network learn from its mistakes and improve future predictions. So backpropagation is an iterative process. So here the model continuously tweaks its parameters after each round of training, gradually improving its accuracy over time. And once the model has completed one cycle of prediction and backpropagation, it doesn't stop there. The neural network repeats this process over multiple cycles, also called epochs. until it reaches the desired level of accuracy. So as the network continues to learn, the loss or the difference between the predicted and the actual output gradually decreases. So the goal is to bring this loss as close to zero as possible, meaning so when it's close to zero, it means the network's prediction are getting more accurate with each cycle. So through this repetition, the model refines its weights and biases until it reaches optimal accuracy. So in real world tasks like MRI analysis, this fine-tuning helps the model to make more reliable predictions, whether it's identifying tumors or classifying different types of tissues. So now let's talk about deep neural networks, or DNN. So these are an extension of the basic artificial neural network, but with a lot more complexity. So the key difference is the presence of multiple layers. So the key difference is the presence of multiple layers between the input and the output layer, which is why they are called deep. So each of these intermediate layers is known as the hidden layer, and they play a crucial role in how the networks learn. So each hidden layer is responsible for learning a different aspects of the data. So for example, in image analysis, earlier layers might learn simple patterns like edges or shapes, while later layers capture more complex structures like specific features of a tumor. And by the time the network reaches the output layer, the DNN has learned to understand the input data more deeply and more thoroughly, allowing it to accurately make accurate predictions or classifications. So now that we have covered how deep neural networks work, let me show you how I have used artificial neural network in my research to reduce respiration-induced signal fluctuations in fMRI. So before I dive into my research, I'll first like to briefly discuss the spore gradient we called echo sequence, which is also called the spore GRE. So this is a key technique in fMRI, and the sequence is shown here on the slide. So spore GRE is widely used due to its T2 star weighing and fast acquisition. So in spore GRE, a spoiling mechanism is usually employed to eliminate any residual transverse magnetization at the end of each TR, and this ensures that leftover signals do not interfere with signals from subsequent TRs. So there are two main types of spoiling. There is the gradient spoiling and the RF spoiling. Here I'll focus more on the RF spoiling because it's more relevant to what I'll be discussing next. So in RF spoiling, the phase of the RF pulse is linearly shifted between TRs as shown here in equation 1, leading to a quadratic phase progression over time as shown here in equation 2. So this process offsets the transverse magnetization excited in one TR from any residual magnetization from previous excitations, effectively preventing interference from prior signals. So despite the effectiveness of spore GRE in fMRI, it is not particularly SNR efficient, which can reduce the overall image quality and limit the ability to perform high resolution fMRI. So now that we've talked about spore GRE, let's move on to talk about oscillating steady-state imaging, or OSSI, which is a novel fMRI acquisition method that was developed in our lab. So OSSI, the aim of OSSI is to improve SNR efficiency for high resolution fMRI. So OSSI leverages two key components, which is quadratic RF phase and balance gradients. So this combination leads to a periodic RF phase progression. So remember the quadratic RF spoiling equation that I showed in the previous slide in SPOL GRE. So also uses a similar concept, but with a critical adjustment. So if we set the spoiling parameter psi of A from the previous slide to 2 pi over NC, we obtain the following sequence here. So here NC is the number of TRs to complete an OSI period, and it's a scan parameter that we get to choose. So what does the OSI signal look like? So the OSI signal is periodic due to the oscillations, and is periodic with a period of NC times TR. The signal is T2 weighted, and this is because of the maintenance of transverse magnetization. The OSI signal is also T2 prime weighted as a result of the different isochromats due to the quadratic RF pulses. So effectively, the combination of T2 weighing and T2 prime weighing OSI makes the signal effectively T2 star weighted, which is ideal for fMRI. So what does the OSI signal look like? First, let's consider an OSI signal with an NC of 10, meaning that the signal is periodic every 10 TRs. So if we simulate a few more TRs, we can immediately appreciate the oscillatory nature of the signal. However, the inherent variability of the oscillations is not ideal for fMRI. So to enhance the usability in fMRI, we stabilize the signal by combining the outputs from each cycle, so also known as the combined signal. Interestingly, when we compare the combined OSI signal to a GRE signal acquired at Ernst angle, we can find that the OSI signal is twice as large. The combined OSI signal is twice as large. So what does the OSI images look like? So this slide here shows different OSI RF phase images from a single OSI cycle, and we can notice different banding artifacts in these images. However, by combining these images over this cycle, we achieve a much more uniform signal, this is what we use for our fMRI analysis. So how do we perform this signal combination? So we essentially combine the signal by using the L2 norm, which is performed by taking the sum of squares across the OSI RF phase cycles to get a single combined OSI image for each fMRI fMRI time series. So while we get a significant boost in signal with OSI compared to the SPOL GRE, OSI is sensitive to temporal B0 changes caused by respiration and drift, and this sensitivity leads to transient fluctuations in the steady state. So this GIF on this slide shows two OSI phase images. And as indicated by these red arrows here, we see respiratory movements, and these respiratory movements cause the banding artifacts to shift over time, and this shifts impact the temporal signal to noise ratio, ultimately reducing the functional contrast in our images. So part of the problem is the L2 norm combination. So while the L2 norm is a simple and effective combination strategy that is robust to the spatial frequency offset that causes the banding artifacts, it does not account for different functional sensitivity between the phase-time courses, or it doesn't account for the fact that the functional sensitivities may change over time. So focusing on this voxel time course indicated by this blue box here, which is if we look at this particular voxel over time, which is the blue line here, we can first see that the signal is drifting over time, and we can also see some fluctuations. And what that is respiration. And we can notice that the different RF phase images, if we look at the same voxel in the different RF phase images, we can see different time courses. So, and if we combine these time courses using the L2 norm combination, we get this signal right here. So mind you, this is an active voxel, and just looking at the signal, we can't tell it is, because the task related signal changes are buried by these distortions. And our goal is to ideally come up with an alternative combination strategy that can help us adaptively combine the signal while taking into account the temporal frequency changes that are caused by respiration and drift. So to address this issue, we implemented an artificial neural network to adaptively combine the signal while reducing temporal fluctuations in the RC signal. So we used a 1D convolutional neural network, and the architecture is shown here. So the network consists of multiple layers of 1D convolution, followed by batch normalization and ReLU activation function to ensure stable and efficient learning. So the inputs to the network is the segmented RC phase time courses. The output is the corresponding combined segments. So once the network, once we get the output from all the segments, we stitch the signal back to reconstruct the full time course shown here. So for our training data, the network was trained with simulated RC time courses generated using block simulations. So these signals were simulated with and without respiration and drift. And the network was tested with both simulated and in vivo data. So these are the MRI imaging parameters for the in vivo data. And the functional task was a finger tapping experiment where the subject was asked to tap their fingers for 20 seconds and rest for 20 seconds while acquiring the fMRI images. And this is to activate the motor cortex of the brain. So this slide shows the results from our in vivo experiment from 3 subjects. So the first column shows the activation map from the L2 norm combined approach, and the second column shows the activation map from our 1D CNN approach. So looking at the second column, we can see stronger activations after the signal is combined by the 1D CNN network compared to the L2 norm combined method. And looking at the voxel time course for a single voxel, we can see that the voxel time course for the combined signal showed in orange has a lot of fluctuations. And when we compare that to the same voxel from our 1D CNN output, we can see that the time course is much smoother with less fluctuations. So now that I have talked about how I have used artificial neural networks or deep learning in my research, this slide will focus on how to get started with your own AI journey. So one of the first steps is to become familiar with the programming language. And in the AI world, Python is by far the most popular choice. Is beginner friendly and has many libraries for machine learning and data science problems. So a solid understanding of mathematics and statistics is crucial, especially in topics like linear algebra, probability, and calculus. These areas are the backbone of many machine learning algorithms. Also, there are a lot of AI and machine learning courses available online for free. One of the most recommended AI courses by Andrew Ng. So he has a machine learning course on Coursera, which covers almost all the fundamentals. I also know that the Camera Initiative with ISMRM Africa offers training in deep learning as applied to MRI. You can also explore platforms like GitHub, where people share resources and projects from which you can learn. Finally, the best way to learn AI is by doing. So start small with projects on GitHub or experiment with tools like PyTorch or TensorFlow. Both are powerful machine learning frameworks. And there are also communities like Deep Learning in Daba that foster collaboration and learning in deep learning in Africa. This brings me to the end of my presentation. Thank you for your attention. If you have any questions, you can send me an email using the email address provided on this slide. Thank you.
Thank you once again for listening to the end of the first speaker. She's unavoidably absent, but if you have questions, I'll be putting a contact in the chat box. You can send them to us. You can send it to her directly. We'll make sure that all your questions are all answered. So I've posted our email in the chat box. So if you have questions, you can send them to us, or you can send them to her directly, and she's happy to respond. Okay, so I'm going to be sharing our next presenter. Our next presenter is Dr. Emmanuel Jackson. He is a neurologist at the Kolebu Teaching Hospital, Ghana. Upon completion of his Ghana College of Physician and Surgeon membership in 2015, he pursued a 2-year neurodiagnostic fellowship at Vancouver General Hospital, University of British Columbia, Canada, where he gained competencies in the use of cutting-edge medical imaging technologies to provide patients with timely and accurate diagnosis, as well as the use of minimally invasive techniques for neurological pain management. Dr. Emmanuel is positively impacting Ghana neuroradiological landscape and a pioneer and delight in training younger colleagues and improving radiological diagnosis. He's going to be taking us through the anatomy, MRI neuroanatomy. So just hold on while we share his video.
Good morning, everyone. I am Dr. Emmanuel Jackson, and I'll be taking MRI brain anatomy this morning. I'm a radiologist with the Kolebu Teaching Hospital. I have no disclosures. The outline for our presentation is going to take the form of an introduction to MRI of the brain. Take a look at the basic very basic MRI phases, descriptive terminologies for imaging findings in MRI of the brain. We look at some important brain sequences, and then we'll go through the radiologic anatomy of the brain, and we'll ask ourselves why MRI of the brain. Then we'll conclude the presentation. By way of introduction, these MRI images create a high-resolution diagnostic images of the brain using non-ionizing radiation. It employs the use of strong magnetic fields and pulse sequences to produce these images. And these MRI sequences are just a programmed set of changing magnetic gradients that are used to produce the images. Protocols are obtained when you have multiple sequences that are grouped with the aim of affecting the various tissues and bringing out the best tissue contrast and spatial resolution. We look at the various imaging planes when it comes to MRI imaging. An advantage for using an MRI is the fact that we are able to acquire the brain images in all these three planes. You have the coronal plane, which helps us to acquire the images in the anterior and the posterior, or dorsal and ventral aspects of the brain. Then you have the sagittal plane, which helps us to see the brain images from right to left and vice versa. Then you have the axial images, which allows us to see the images from the cranial to caudal. Okay, so we have three planes that are employed: the coronal, the sagittal, and the axial plane. Before we understand the various images that are acquired by the MRI, we need to know a little bit about the physics behind it so that we can interpret the kind of signals and the images that are produced. In the body are free protons within the various molecules in the body, and we know that majority of the body is made up of water, which has hydrogen ions and other ions that are randomly oriented in the body. So when somebody is placed in the MRI scan machine, the scan machine has a strong magnetic field which aligns all the protons in the body towards the field of the magnet. So it will be in like a north-south orientation according to the magnetic field of the scan. A radio frequency pulse is employed, and this causes the various protons to align, or they are excited. So they are aligned at an angle to the magnetic field. And these radio frequency pulses then cause the protons to spin in phase with each other, creating resonance. When these radio frequencies are shut down, it causes the excited protons to relax, and it gives off a radio frequency signal which is detected by the MRI scan. When the radio frequency pulse is shut down, the protons will then realign themselves to the original position in the magnetic field of the MRI. This realignment of the protons, coupled with defacing of the spinning protons, that is, they lose the resonance which they had whilst they were being aligned at an angle to the magnetic fields. These two processes, the realignment and the defacing, is used to generate the signals that we see on an MRI. So a T1 signal will relate to the speed of realignment of the magnetic field, and this happens more quickly when the protons realign. The greater the T1 signal will be, and the T2 relates to the speed of the proton spin defacing. The slower the defacing, the greater the T2 signal will be. So this is just a very basic explanation for the MRI images and how they are produced. So we talked about the radio frequencies being used to excite the protons. So the time for repetition and time to echo describes these processes. So echo time, that's a TE, is a time interval in which signals are measured after the radio frequency excitation. The repetition time denotes the time between two excitations, and as I said, when the magnets aligns the protons, we send in the radio frequency pulse, they get excited, we put them off, they realign or they dephase, and they give signals, then we reapply the signals. So a repetition of all these signals and the pulses is what is going to give us the images. So when you vary the times of the echo and the time for repetition, then you are going to have a T1 weighted image or a T2 weighted image. To get a T1 weighted image, they use a short time for repetition and a short time for the echo. That is roughly below 1,000 milliseconds for the TL and 45 for the TE. And for a T2 weighted image, the TR and TE are long. So how do we describe the images that are seen on an MRI scan? The MRI scan can be likened to a map of proton energy within tissues of the body or the brain, as in this case. A variety of the images can be produced which emphasize different tissue types, and in particular those that contain a large amount of fat or water. Unlike CT and X-rays, which can be described as a map of density of tissues in the body, whereby very dense structures are seen as being white and fluids, less dense objects like air and fat are very dense. On the MRI, when we see a high signal intensity, it's going to be seen as being white, and we use the term signal instead of density. If there's intermediate signal intensity, that means the structure normally will appear gray, and in the brain the reference point is the gray matter, which is the cortex. And if it's dark or black, then the signal is said to be low or hypo-intense. So remember, we use signal intensity instead of density as compared to CT and X-ray images. So let's take a look at this CT and MRI images of the brain. Both are centered at the level of the corona radiata, or the body of the lateral ventricles. So to the image on our left here, we see that we have a shade of very dark to white, or black to white. And if we start at the central portion, we see this paired structure, which is the body of the lateral ventricles, and it contains the CSF. CSF fluid is dark, right? And as we go towards the periphery, we see the gray looking white matter, and the cortex being slightly lighter or brighter than the white matter, which is the gray matter of the brain. And we see this circumferential ellipsoid white density, which forms the skull of the patient. So we said that on CT, the denser the tissue, the whiter the image we are going to see. So less dense, more dense. Okay, all right. On the MRI, we can likewise see the same image of the brain at the level of the body of the lateral ventricles. So the midline structure here, we see some white signal within the lateral ventricles, which connotes the CSF within this space. So we'll say hyperintense signal of the CSF within the lateral ventricles. Then once we move to the periphery, we appreciate the dark white matter, right, compared to the gray matter at the periphery of the cortex, right? And see that at the skull or calvarium, we see that it has the dark cortex, right? Dark cortex, and the diploid space is slightly lighter. Then we appreciate the subcutaneous fat of the scalp, which is also bright. So we have hyperintense signal, let's say hypointense signal, isointense signal, and we have another hypointense signal of the calvarium, the cortex of the calvarium, right? So let's look at some important brain sequences, and as I said, these can be varied to give protocols depending on the indication of the MRI. So basic ones, you have a T1 weighted, a T2 weighted flare or stir sequence. You have the DWI, the ADC, and we'll look at the GRASWI. We'll go through the full names. Post-gadolinium T1 images. You can have the MR angiogram, venogram, the spectroscopy, CSF flow, MR perfusion, and DTI, the diffusion tensor imaging. So there are more images that we can use the MRI to obtain. So let's look at the T1 weighted images. These are best for neuroanatomy. We are able to look at the anatomy of the brain structures well. So we always employ looking at the T1 weighted images when you are assessing anything within the brain. And the T1 is also best for post-contrast evaluation because of how the relaxation time is on the T1 post-contrast administration. how are we able to tell on the brain which imaging is, if the imaging is T1 or not? So the white matter appears white, that's the areas around the ventricles, they appear white, and the cortex, which is the gray matter, they appear gray. Okay, so there's a popular saying, on T1 white is white and gray is gray. Simple, so that you can follow and be able to pick it up. There again, if you can see here, the ventricles, which contains the CSF, is dark. So let's look at some of the structures that appear dark on T1. So we have fluid, which is the CSF, bone, the cortex of the bone here, cases of infection or inflammation, and hyperacute or chronic stages of any hemorrhage. They are also going to appear dark if there are calcifications. Most tumors will also appear dark on T1, as well as hair will appear dark on T1. However, if you see any bright signal on T1, it's also a clue that you should follow up what this bright signal is to arrive at your diagnosis. So T1, fat, if there is any subacute hemorrhage, right? So anytime you see blood that is hyper intense on T1, you should be thinking it's in the subacute stage. Okay, melanin, if there's slow flowing blood or thrombus within the blood, if there's proteinaceous fluid within the sinuses, or there's a postgadolinium image, all these will show us bright signal on T1. On the postgadolinium images, it shows us bright signal on T1 images, and it helps us to detect focal lesions such as abscesses, tumors, metastasis. It's employed in the venogram and angiogram of the MRI of the brain, and in advanced cases can be used in evaluating the parameters of MR perfusion. So we see this image, which is centered in the posterior fossa of the brain. This is the T1 weighted image, and there's something in the cerebellopontine angle on the left, right? It's the pons in the cerebellum. It's hardly appreciated because it looks iso intense to the rest of the posterior fossa structures. Upon gadolinium administration, we see an avidly enhancing lesion in the left cerebellopontine region, which extends into the internal auditory canal at this level. So post-contrast helps us to find lesions that are enhancing, or it helps us to really delineate lesions that have broken the blood-brain barrier. The T2 weighted images are very good for showing pathologies because the fluid contents show us hyperintense signal, right? We see in this image the central ventricles showing the CSF, which are hyperintense, right? The periventricular and deep white matter appear darker than we saw on the T1 weighted image, and the gray or the cortex appears now brighter than the T1 image. Okay, other things that showed us dark on the T2 include moving blood, bone calcifications, chronic blood, acute blood, subacute, the early subacute blood, and air. These others are bright, and they include most tumors, infection, inflammation, the late subacute hemorrhage, and fat. Okay.
Hello, is there loss of volume?
Yes, there is. We
Yes,
cannot hear the presenter again.
Yeah, we cannot hear him.
So
Jackson,
a
are you online?
summation of the findings: take CSF is dark on T1, bright on T2, and dark on the flare. White matter will appear light on the T1, dark gray on both T2 weighted and flare. The cortex will appear gray and on T1, light gray on T2 and flare. Fats will be bright on all sequences, but less so on the T2 and flare. And if you have any inflammation, infections, demyelination, it may appear dark on T1 and bright on T2 and flare. The diffusion weighted image measures the random Brownian motion of water molecules within the voxel of tissue, and higher cellular tissues or those with cellular swelling exhibit lower diffusion coefficient, so the ability of water to move within the tissues. If there's any disruption, then we say that the diffusion weighted image will show as an increased signal, right? And the diffusion weighted image, or the DWI, is normally goes hand in hand with an ADC, right? So the ADC measures the magnitude of the diffusion within the tissue, and this is done by the computer. So the main reason why you have to look at the ADC in conjunction with the DWI is that sometimes you can have a facilitated diffusion or T2 shine through, in which the signal on the ADC is high. However, for us to have a true restricted diffusion, the signal on the ADC should be low. So if you have a high signal on DWI and there's a corresponding high signal on ADC, then that is just a facilitated diffusion or T2 shine through. DWI ADC is employed in ischemic stroke, abscesses, epidermolysis, the groups of CJD, acute encephalitis, and the rest for us to make a diagnosis. Right, so this is an image that shows abnormal collection in the right basal ganglia, and we see this high signal on the DWI with corresponding low signal on the ADC. Right, so this is a pyogenic abscess. Okay, there's DWI, ADC, and T2 weighted image sequence in ischemic stroke, whereby after 24 hours we start, appreciating the abnormalcy and between 7 days to 30 days, it will peak and start becoming hypo intense. The DWI very early on will show abnormal high signal changes and will peak after the 24 hours to 7 days and starts gradually becoming hypo intense in the chronic phases. The ADC will start off by being hypo-intense. The region of ischemia will be hypo-intense, and after 24 hours will start normalizing and gradually become hyper-intense in the chronic phase. So in the chronic phase, we expect that the DWI will be hypo-intense and the ADC will be hypo-intense. Then we have the gradient record echo and susceptibility weighted images. Both of these images are used to detect small amounts of blood products and calcification due to their sensitivity to local susceptibility effects. The SWI is an improved version of the GRE and helps to detect small quantities of blood, be able to tell if it's an arterial or venous vessel, and also be able to differentiate calcifications from blood products. And it's more sensitive than the GRE for looking at cerebral microbleeds. So here we have an image. The left image is the SWI and this is the GRE, and we are able to appreciate the multiple hypointense tiny lesions within the deep brain matter and the cortex compared to the GRE where the abnormal hypointense signal changes are minimal. Let's look at MRA and the MRV, that's the angiogram and the venogram. We're looking at how we will study the anatomy of the vessels, the arteries and the veins. A time of flight is commonly used for the MRA because it's fast to obtain the images and we do not need gadolinium. However, they are susceptible to flow phenomenon and sometimes artifacts because of the way the tortuous vessels are, and they create the impression that there's narrowing or stenosis within these arteries. It can be performed by both 2D and 3D techniques. And we can also employ contrast on MRA, and especially when you are dealing with neck vessels and patients that have stents or coils being placed. As in the era now that we are using coils in the treatment of aneurysms. The MRV also employs both a 2D and 3D technique with the use of the time of flight, and we can have a contrast enhanced MRV, which is less susceptible to artifacts. Now, this imaging of the blood helps us to visualize territories of the brain, look at stenosis or occlusion of these blood vessels, if there are any aneurysm, malformations, or even thrombosis within these vessels. So this is a 3D MR venogram which depicts, and this is the oblique and this is in the transverse form. We see the superior sagittal sinus, which the cortical veins will drain into, and it forms at the trochlear you have the straight sinus, you have the transverse sinus, the right is the left, forming the sigmoid sinus and the internal jugular vein, right? We also appreciate here the vein of Labi, which drains into the junction of the transverse and sigmoid sinuses. Okay. The MRA, you best appreciate the circle of Willis, right, in which you have the anterior communicating artery joining the ACAs, that's the anterior cerebral arteries. You have the middle cerebral arteries and its branches, which joins the posterior cerebral arteries by the posterior communicating artery, which is better seen on this lateral or sagittal view. Okay, so the basilar, which is formed by the two vertebral arteries, then branches into the left and right PCA. Okay, all right, so on this sagittal image we are able to see the ICA, this anterior portion, this is the posterior portion, right? So you have the ACAs, the MCAs, and you have the PCAs. Let's look at the
Hello, Jackson. Shola, what's wrong with the video? We can't hear. Hello, Jackson, can you come online? And I think let's...
I sincerely apologize for the loss in it was internet logistics, and then I'll resume the video and back it up by 3 or 4 minutes.
Hello, Jackson. Jackson, you're online. I was just thinking, or maybe Jackson, you could speak to at least the last slides. Dr. Jackson,
Hello, sir.
how are you? I said you could speak, maybe just speak to the last slides while he's loading. Yeah. Okay. All right, no problem. I think he's back. All right, Shola, this is fine. What I'm saying is that Jackson, you to also speak to the slides while we're loading the video, talking about the MRA and MRV. Jackson, I said if you're online, I said you could speak to the about the last slides, about talking about the MRA and all that, while we continue with the trying to connect. Unmute yourself, Jackson, and speak.
Yeah, good morning, everyone. So just trying to explain that the MRA and they are used so that we can outline the various brain vessels, the arteries, and the veins. And in the picture, it was just showing how the vessels extending from the neck gets into the brain through the internal carotid arteries. They form the circle of Willis. Then we have the major branches, the anterior supply and the middle cerebral supply. Then you have the posterior circulation to the brain that's coming from the vertebral arteries, and they supply the cerebellum and the occipital regions, and they all have some connections. So the MRA will help us to be able to outline these. And when you have indications where in a person with stroke, then we are trying to see if we can outline any areas of vascular narrowing or occlusion. And if the patient has the subarachnoid bleed, we are looking for areas of aneurysms. So any outspousions within the vessels will be seen with these MRA. Okay, so these are the helpful use of the MRA in imaging the brain. It helps us to see the various vessels. I don't know if we are still having internet issues.
I think Shola is having problem with the slides. And anyway, meanwhile, I think for the most part of the presentation so far, I don't know if people have questions they could ask since Jackson is online. I think this is a good point to at least have some interactive sessions to ask Jacksons about the, the MRI anatomy, the MRI sequences, and all that. So if we can have questions, I think it would be nice to ask them now. Just to kick this thing out, Jackson, just one interesting question while people are still booting to ask their questions. I want to ask, when you're talking about the sequences, what is the significant difference between DWI and SWI?
Okay, so the DWI is about the motion of the restricted motion of the Brownian motion. So if it goes with the ADC, so the two of them are used, and they are quite specific for certain things. So if they are positive, let's say we say there's restricted diffusion, then some differentials will come to mind. First, you are looking for an acute infarct, and a positive or restricted diffusion shows an increased signal on the DWI and a reduced signal on the ADC. Just the SWI is to help us pick up susceptibility or blooming artifacts caused by microhemorrhages and calcifications. So there are two quite different uses. The DWI and its restriction will help in cases of an abscess, or if there's a lesion that has a high cytoplasmic to fluid ratio, or is very thick, like a lymphoma. Such a lesion will show restricted diffusion, and so will have a bright signal on DWI and a dark signal on ADC. If some viral infections like the CJD will also have some restricted diffusion. So when we have a set of images and you see restricted diffusion, then you'll be able to narrow down your differentials to be able to get a diagnosis for the patient, coupled with the history that you've been provided. So those are the differences.
For your excellent answer. I think there's another question. Said, could you tell us about the clinical application of MRS? Could you tell us about the clinical application of MRS?
Okay. So MRS, just like the other MRS, just like the other modalities, it's a useful tool which helps us to also differentiate or be able to narrow down on our differentials. Okay, so it's also a non-invasive technique, and it deals with the chemical compositions of tissues, particularly that of the brain. And the MRS will use concentrations of these specific molecules like choline, creatinine, and acetyl aspartate, right, to help us find out how well the tissues are doing. So a variation of these compositions and the various ratios help us to sieve out our differential diagnosis. So like if you take the N-acetyl aspartate, NAA, is a marker of how well the neurons are doing and its integrity. Choline indicates cell membrane turnover, and they are mostly elevated when you have tumors or inflammation. So clinically, you can help in differentiating the various tumors, right, based on the chemical composition and the graph that it gives you. Neurodegenerative changes can also, MRS can also be of help, where you monitor disease progression and treatment effectiveness. Okay, conditions like in Alzheimer's and multiple sclerosis. If you have stroke, sometimes to the damage suffered by the brain cells can be used to MRS can be used to predict how if the patient is going to get some recovery or not. And in other neurological conditions. It's helpful in diagnosing and monitoring patients, such as those with epilepsy,
Thank you very much,
infections, or
Dr. Jackson.
metabolic disorders.
This is my audio.
Excellent. Thank you so much. Do we have other questions for Jojo Jackson? Do we have other questions? Do we have other questions? Please go ahead and unmute yourself and ask your question. Go ahead and ask your question. Ibrahim Haruna.
Yes. Hello, can you hear me?
We can hear you. Go ahead.
Sorry, I'm a bit late.
Ibrahim Haruna, you are muted. Okay. Go ahead and ask your question.
While we are waiting for the person to
Okay,
ask his
put the question in the chat. Okay, go ahead and put the question in the chat.
See some questions. Monsura Ahmad said, what would you advise a recent graduate of medical imaging who wants to specialize in neuroimaging? What courses can you recommend to get started? Also, there are two questions. Now, the second question, during the course of his professional journey, is it open to biomedical engineers and radiographer, or is it just for doctors? I probably it means radiologists. Is it open to other specialty apart from radiologists? Those are two questions.
I thought that question was for
Dr. Jackson.
the question was for the last lecturer, anyhow. But I think I tried to answer it in the chat in my reply. Okay.
No, I think it's for this one is on neuro. It's for Dr. Jojo. I
Okay,
think
all
he's
right.
training in Vancouver.
Okay, okay. Doctor,
Oh,
why?
really, I don't think the question is directed at me. Okay, who wants to specialize in?
I think the person asking must be a radiographer or biomedical engineer. So he's asking if he can specialize in imaging or neurodiagnostic fellowship.
I'm not too sure about the radiographers and their courses because this one is for the fellowship. It's for radiologists.
I think we should go ahead and ask questions that are relevant to this lecture. Let's go ahead. We can ask the question by Magnus. Magnus is asking, what protocol is best for epileptic diagnosis?
Well, for epilepsy, you should have underlying cause in mind. So mostly you're doing a high resolution T1 weighted images because, as I said, the anatomy of the brain is very important in understanding the causes of an epilepsy, especially with the hippocampal and the medial temporal region. You want to evaluate them well. You want to look out for heterotopic tissues. So the high resolution T1 images are very important. FLAIR images, that's the fluid attenuated inversion recovery sequences, to look out for areas of increased signal intensity that can indicate that there's been brain damage or abnormalities there. Then the imaging plane has to also go through the hippocampus when we are looking out for temporal lobe epilepsy. There again, we can add sequences like the SWI and DWI to also help us looking out for hemorrhages and other causes like infections and stroke. Thank you.
Okay. Thank you very much, Dr. Jackson. I think other questions, we'll collate them later and send to you. Our next presenter is Professor Andrew Webb. He's going to be taking us through basic MRI techniques and sequences. Professor Webb is a professor of radiology at Leiden University and the founding director of Gotha MRI Center at Leeds University Medisch Centrum, LUMC. His expertise lies in MRI, medical imaging technique that uses powerful magnetic fields and radio waves to visualize the inside of the human body. Professor Webb's work extends beyond research and academia. He focuses on developing accessible MRI techniques that offer new opportunities in both developed and developing countries. So join me as I welcome Professor Webb.
I join you in welcoming Professor Webb. Thank you, Shola, for that brief introduction. Professor Webb is one of our main global supporters, and we are very excited for him to present in this meeting. Thank you. So we'll play a video just because of the low bandwidth of our internet, but Professor Webb is online and has been online since morning, and he will be able to answer our questions. Thank you so much. Shola, please go ahead.
In this presentation, we're going to go over some basic MRI sequences and MRI techniques which are used to produce images with different contrast in the clinic. So we're going to start off with looking at different types of sequences and different types of contrast that we are going to use for clinical applications. So we'll look at things like inversion recovery, spin echo sequences, and then we'll
Just to be sure, can you see my screen?
You can see your screen, but it's not full screen. Yes, please.
Okay.
Just go ahead.
look at contrast, T1, T2, proton density, and a few more specialized contrasts. From an MR point of view, then, we can sort of break things down into, for example, excitation pulses and refocusing pulses. So we'll take a look at those and see what those do. We've then got things like inversion recovery, which is a 180-degree pulse and then a 90-degree pulse, and spin echo, which is the opposite, a 90-degree pulse followed by a 180-degree pulse. And these are modules that can be used to produce quite different contrast in our clinical images. And so we'll look then at how do we construct different sequences from these basic modules that can be used to give us all the different contrasts that we're interested in. And then finally, we'll look at some more specialized sequences that can be used to encode different diffusion or different blood flow, in other words, angiography, into the image information. So if we look at Radiopedia, which is a very good source of information, I'm not going to read through this, but essentially it's saying that if we look at all of the sequences that we're going to run in a given protocol, and there may be 6 or 8 sequences, then they're either proton density weighted, in other words, the signal intensity depends on how many hydrogen nuclei there are in every single voxel. They're T1 or T2 weighted, which again means that the signal intensity depends on those 2 relaxation times, or they may be diffusion weighted or flow sensitive. But in addition to this, we can also add these, what they call optional add-ons here, such as putting a combination of different RF pulses that actually attenuate the signal from fat or attenuate the signal from fluid. Or, of course, we can add contrast agents, which are going to be used particularly in, say, tumor studies or lesion studies, which are going to highlight where a small lesion may now come out of an area of very low contrast with the surrounding tissue. So if we look at these, then a T1 weighted, from a clinical point of view, is typically gadolinium enhanced, as I just said, and it's fat suppressed. And the reason is that on a T1 scan, fat appears bright. And we'll see this as we go through the lecture. T2 then also can have a bright signal from fat, and so we want to get rid of that. We also may want to get rid of the fluids. For example, if we're doing a brain scan, the CSF, because again, that has a very high signal, and that's going to drown the area that we're looking at. And T2 can be sensitive to susceptibility. In other words, areas, let's say in the brain, or more commonly in the body, for example, in the liver, where we have a high concentration of iron. Proton density images then, again, are typically fat suppressed because the fat is not really giving us any information. If we look at flow sensitive ones, then we can look at either angiography, where we're basically looking at the arteries, or we can do venography when we're looking at the signal coming from the veins. And again, depending on the particular clinical application, we can use either one of these types of sequences. And then there's a whole range of sequences which are used for specialized applications. So functional MRI, diffusion tractography, MR perfusion, etc. So these don't form a typical part of the arsenal of a clinician, but they may be used particularly, let's say, in tumor studies or functional MRI if we're going to be planning surgery after the MRI. So let's start off by looking at a T1 weighted sequence. And typically this is the first sequence that is run on a scanner. It may take 2 or 3 minutes, and it's basically an anatomical image. So it may not have incredibly good contrast between the different tissues in the brain or between, let's say, a lesion and the surrounding tissue. But it gives us a pretty good idea to start off with about whether there is any gross anatomy within the brain. And so if we look at the signals from different tissues, anything that is fluid, so in other words, if we're looking in the brain at cerebral spinal fluid, or if we're looking in the body, we might have urine, or we might have amniotic fluid if we're looking at somebody who is pregnant, then those type of materials have a very, very long T1. And what that means is that they appear in a T1 weighted image to have very low signal intensity because they don't have time to relax back, as we heard about in the first lecture. And that means that they are somewhat black. And so that's quite useful because it means that we're going to get rid of these very, very high signal intensities. If we're looking at muscle, let's say if we're looking around the knee, something like that, typically that always has an intermediate signal intensity. As you mentioned before, fat has a very high signal intensity. And so if that's a problem, if that's in an area which we're interested in, we'll want to do some fat suppression, talk about that later. If we look at brain then, between white matter and gray matter, there is some image contrast there. And then typically we have the white matter then giving us a slightly higher signal intensity compared to the gray matter. So this is the easy way of remembering white and gray as being higher signal and lower signal on a T1 weighted sequence. On a T2 weighted sequences, then this is the one typically gives us the most contrast. And so these are the ones that we typically run at very high resolution, and they'll take a little longer than the T1 weighted sequences. And so again, if we look at the fluid, and we look at, again, CSF, urine, etc., these have a high signal intensity. And so they're very useful for looking at things like edema. Again, muscle and fat, the same as before. If we look at brain here, we see that gray matter, white matter, again, a little bit of contrast, but notice that the contrast is different. It's flipped with respect to the T1. And so one of the dangers is that if we have sequences which are mixed T1 and mixed T2 contrast, we may actually end up with very, very little contrast between the white matter and the gray matter. Proton density weighted images not so much used in the brain. And one of the reasons is they take a relatively long time to run. And in fact, pathologies may not have a different proton density than healthy tissue. And so these ones are much more run, let's say, in knee scans and in other parts of the body. But again, if we look through, we can see fluid, again, high signal intensity because there's just more hydrogen nuclei there. Muscle, intermediate. Fat, again, has a lot of protons. We've got then cartilage, and we've got fibrocartilage. So hyaline cartilage is the more mobile side of cartilage. Fibrocartilage, as it suggests, is something that is bound more tightly, and that gives us a lower signal intensity. So in terms of looking at cartilage then, and abnormalities in the cartilage, proton density is quite a good weighting. As we said, fat often is a bright signal, and unless we're particularly looking for fatty infiltrations, let's say, into the liver, if we're looking for NASH, something like that, then the signal itself is not particularly useful. And so we're going to try and look at ways to get rid of that. And similarly, the situation with fluid, that CSF gives us such a lot of signal, and often that is going to drown the background if we're looking for small lesions. And so we're going to look at sequences where the fluid is attenuated in terms of its signal. So let's just look at a couple of typical neurological protocols that run through. So if we start at the top here, we've got a T1, like we said. It's an FFE, so that's a fast field echo or a gradient echo sequence. Next, there's going to be a T2, which is a TSE or a turbospin echo. Come to these a little later on. In this case, there's an SWI, which is a susceptibility weighted image. So this is going to help to pick up any areas where we have ion accumulation. We've got a flare image, and that's a sequence that is used to suppress the signal from CSF. And then we've got a DWI, a diffusion weighted image. And so as you see, we've got here 5 different sequences that are going to be used, and this will probably take about half an hour as an imaging protocol. If we go to the knee then, we typically run a slightly different kind of protocol. And you'll notice here there's a lot of fat suppression, so this technique called SPARE. Almost everything here is TSE, and so we're going to look for very high resolution images. You can see here looking at slices 2.5 millimeters with very small gaps in between, relatively small field of view. And we can see here that they're run in many, many different orientations. So 2 in the axial, 2 in the coronal, 2 in the sagittal. And here we're looking because the slice is typically thicker than the in-plane resolution. And we really want to see isotropic resolution. We want to see high resolution in all 3 axes. So one of the ways that this is done is to run these 3 different protocols. And typically a knee scan might take a little bit longer, but also it's much easier to keep your knee still than it is to keep your head still. And so these can typically run a little longer than brain scans. And as we're going to look at T1s and T2 weighted, this is just a slide which you can look at later at your leisure, which lists all of the different values. You can see that the T1 times typically go up as a function of field strength, and the T2 times go slightly down, particularly in regions where there is ion deposition. And so we can ask ourselves physiologically, why the different tissues, particularly when they're healthy or diseased, why they have different T1 relaxation times. And what we can see is that there are contributions from macromolecules, from proteins, cell membranes. So if you tend to get a buildup of those, then we're going to find that the R1 is going to increase, and that means the T1 is going to decrease. Again, similarly with iron, as I've mentioned, and also contrast agent, if those are there, then the R1 is going to go up and the T1 is going to go down. So the signal intensities on T1 weighted images are going to be higher. And so if we look at iron concentration, for example, here's a case in the liver. This is hemochromatosis. So if you look in the liver on the left-hand side, you can see where the signal from the liver has completely disappeared. And that means there's a large amount of iron there. And although iron would give you a slightly higher signal intensity on T1s, it really decreases the T2, and that means there's almost no signal coming there. And if we look in the brain, the same happens with microbleeds, where we've got a deposition of iron. And so these are typically very easy to see as areas of low signal intensity. Okay, so that's sort of from a clinical point of view, what we're able to do and what is interesting. So how are we going to be able to get this different image contrast, having learned about the basic MRI physics? Well, there are two basic kinds of sequences. One is called a gradient echo and one is called a spin echo. So if we start from the gradient echo sequence here, and this may be called fast field echo, gradient echo, depending on which vendor you've got, then we run our standard imaging sequence. And we have what looks like this sort of quite complicated equation in terms of what the image intensity at every single voxel, xy, in the image is. And it depends on a number of terms. First of all, this term in rho, which is obviously how many protons there are in each voxel. So that's the proton density. There's a term there in terms of our repetition time, TR, and our T1 time. And that's going to give us a T1 weighted. We also have the flip angle, alpha. So alpha is typically less than 90 degrees there, but again, by changing that, we can change the contrast. And then we have the T2 term. And in this case, with the gradient echo, we have this T2 star term, which is going to include inhomogeneities in the magnetic field. So if we look at that equation, and we just look at the different parameters that we can put in, then we can see what kind of image weighting we get out as a function of the imaging parameters. So for example, if we want to have something that is just weighted by the proton density, the rho xy on the top line, we essentially want everything else to either go to 0 or to go to 1. And so if we take for our TE, and we make our TE very, very short, compared to the T2 and the T2 star, you can see that the term on the right-hand side essentially goes to 1. So different tissues with different T2s give the same signal intensity. The signal intensity does not depend on the particular value of T2 if T is much, much less than T2. The same is true if we have a TR being much greater than T1. You can see that that exponential again is going to go to 0, which means the term inside the brackets is 1. And so it doesn't matter what the T1 value is. The signal intensity is going to be the same. So if we just want the image to be weighted by the proton density, then we can set our TE time to be very short and our TR time to be very long. Now, obviously, that gives us a very long imaging sequence. So if we can't afford that time, then what we can do is cut down our TR a little bit here. But then we have to use a very low tip angle, alpha, and alpha might be, let's say, between 5 and 10 degrees. And again, if you look at that, and you look at the terms in the equations, that means that our signal is not going to depend on the T1. And we can apply the same analysis then to getting a T1 weighted sequence. So we want no T2 weighting, so TE is much less than T2, but we do want T1 weighting. So we can have a TR on the order of T1, and we can have a relatively high tip angle. And if we want to make it T2 star weighted, then we want a very long TR, so there is no T1 weighting, and we want our TE to be a significant fraction of T2, so now our signal does depend on the T2 of the tissue. And so within that gradient echo sequence, we can essentially choose those parameters, and those are entered from the console, and those will give us the 3 different weightings. A spin echo sequence then is different in the sense that, as you see on the right-hand side, we have a 90 and a 180 degree pulse, which are causing the spins to refocus. So the 90-degree pulse flips the spins down, they dephase, the 180 flips them over, they rephase, and they give us our signal. So any effects of B0 inhomogeneity are going to be refocused by this sequence. And in fact, what we do, a spin echo by itself would be quite a slow sequence, is to run what is called a turbo spin echo sequence, which might be TSE or a fast spin echo sequence, again, depending on which vendor you use. And essentially here, what we do is we keep refocusing the magnetization, and that gives us a much more efficient way of collecting a series of spin echoes. And we can effectively decide how many echoes that we want to collect and in what order going through K-space, which will affect the effective echo time that we use. And again, using a very simple equation, so slightly simpler than for the gradient echo, because we're going to assume that your pulses are 90 and 180. Once again, by simply choosing the TEs and the TRs, we can come up with something that is proton density T1, T2, or a mixed T1 and T2 weighted sequence. And so if we look at a typical brain scan, and we look at the top left in A, it's got a short value of TR, and it's actually got a short value of TE, right, only 10 milliseconds. So what that means is that it's got a highly T1 weighted contrast there. Now, if we make our TR much larger, that means that it reduces the T1 weighting, as we can see in B. If we look in C and we want to get a T2 weighted image, then what we want to do, if you remember, is keep a long TR, but also to have a long TE. And so if we increase our TE here to 35 milliseconds, we start to get T2 weighting. And if we look at the last image in D, where we have a very long TE of 100 milliseconds, we've got very high T2 weighting. And what you can see there, if you look at the bright signals, they're coming from the fat on the outside, and they're coming from the CSF, which you can see there surrounding the cerebellum. So depending what kind of sequence we want, we can change just the parameters that we use to acquire them. Now, if we want to add in some extra contrast, we can look at, for example, what is called an inversion recovery module. And this is going to be very useful if we actually want to get rid of the signal from certain components of the brain, let's say, or if we're imaging the knee. And the inversion recovery essentially is two pulses. One is an inversion pulse, 180 degrees, which tips all the magnetization into the minus Z direction. We wait a TI, time for inversion, and during that time the Z magnetization recovers with a relaxation time of T1. And after a certain time, then we apply the 90-degree pulse, and then we have our standard imaging. Now, if you look at, I've drawn two different graphs here in red, corresponding to two different tissues. If you look on the left-hand one, and you look at the green arrow, you can see that if we were to await that TI time, then there is no magnetization. And that means that when we image, we will get no signal from that particular tissue. But you can see that the signal on the right then has some intensity. Whereas if we were to have a second inversion time, a different one, where on the right-hand side that red curve passes through 0, then we have, again, no signal from that, but we have a nice positive signal from the other one. So by choosing our TI, we can change the contrast, and in the extreme case, we can null the signal from one component. So if we look over here, then, let's look at the FLAIR sequence. This is called a fluid attenuated inversion recovery sequence. And as we can suspect from the title, then, anything that is very fluid, in other words, CSF, is going to be nulled. And so here's the sequence. Again, inversion recovery. And look at the TI here. We choose the TI such that the CSF signal is 0 when we run the imaging module. CSF has a very long T1. And so at that point, that particular TI, we have positive signal from white matter, we have positive signal from gray matter. And that means that we're going to get an image like this. And if you look at the ventricles or you look around the brain, you can see that it's dark. And that means that the CSF signal has indeed been nulled. We can take this further and say, in certain cases, certain clinical conditions, we want to annul both the CSF and, let's say, white matter, in which case we use what's called a double inversion recovery. And again, here we simply take our inversion recovery module and we add another inversion pulse before it. So now we have two inversion times, a TI1 and a TI2. And if we do that and we look at the magnetization, we can see the graph we already saw for the first inversion. But now after TI1, we invert again and we wait a second time, TI2. And you can see if we time those two correctly, you can see that signal intensities from two different tissues can be nulled. In this case, you see white matter and you see CSF going through 0. And again, if you do that, then you can get an image that looks like this. And so we see very nice contrast now, high intensity just coming from the gray matter. So simply by playing around with pulses and with delays then, we can change the relative signal that is coming from each of the particular tissues. Now, I've said a number of times we might often want to suppress the signal from lipid. And how are we going to do that? Well, the easiest way is to look at the fact that the protons in water and lipid resonate at slightly different frequencies. And so if we look at this at 3 Tesla, there's a frequency difference of almost 400 hertz here. And so what that means is that we can do what is called a non-selective inversion over here. So we could just put in a 180-degree pulse, and we could invert, in other words, take the MZ to minus MZ for all the water and the lipid. And because they have different T1s, we could wait a certain amount of time until the signal from the lipid is 0, and then we could run the image and we just get a signal from water. But you can see that's not the most efficient way of doing things, because when the lipid signal is 0, the water signal also will have relaxed a certain amount. And so an alternative is a selective inversion. And so this obviously goes by spur or spare if it's an adiabatic pulse. And you can see here that we don't touch the water signal. In other words, that we've used a selective frequency pulse that only affects the lipid, that inverts the lipid. We'll wait a certain time, Ti, until the lipid signal is 0, and then we'll image. And notice that because we haven't inverted water, we can get full signal intensity from the water in any of the tissue. And so here's a kind of an example of using one of these sequences where you see the fat signal is 0. So normally there'll be a very bright signal all the way around the muscle, and that's 0. And what you see then is the muscle signal. You also see some flow. So the high intensities there are areas where you're seeing vessels running through the muscle, the leg muscle in this case. So this kind of fat suppression is very, very often used in musculoskeletal imaging. Now I'm going to finish off by just looking at a couple of specialized sequences that again are going to build upon this idea about different RF pulses, but now we're going to add in some gradients as well to try and encode different information. And one of the most useful things, particularly in studies of stroke, is diffusion. In other words, how fast does water diffuse in a particular tissue? And that changes dramatically when you have cellular damage. And so what happens here is that we take our basic spin echo sequence, our 90, 180, and we add in 2 gradients, lobes here. You can see these are just in gray, given by a certain gradient value, G diff. And these are placed either side of the 180 degrees pulse. Now, if we think about what happens, let's look at that first gray lobe of the gradient. That's going to induce a certain phase in the signal. And the phase of that signal depends on the value of the diffusion gradient and how long it's applied for, that little delta. So we might get a phase modulation of, I don't know, let's say 30 degrees or something like that. Now, let's suppose we look at the second one. Now, the pulses, there's a 180-degree pulse, which means the phase of those spins are going to see is going to be opposite to before the pulse. But let's suppose those spins do not move at all. In other words, we have something that is very rigid. Then what's going to happen is that difference is going to be the same before the pulse and after the pulse. In other words, you've got a phi diff on the left-hand side, and you have a phi diff on the right-hand side, and they will cancel each other out. And so you won't get any signal attenuation. There's going to be no net phase accrual there. But if they move from a position Z, say, to a position Z prime, so if you have something like CSF, where the water molecules diffuse very fast, they're going to be in different position before the 180 and after the 180. Then you're going to acquire a certain phase, and what that means is that you're going to dephase your signal, and your signal intensity is going to go down. And so by putting these 2 gradients in, we have encoded the rate at which water molecules diffuse in tissue. And if we write this down, we can do it in terms and it basically says how much is the diffusion. And so if you look at this, we're going to get, let's say in the case of a stroke, we get a situation like this, where we can see a very bright spot then that is corresponded to restricted diffusion inside the brain. And this is very, very sensitive. So sometimes you will see something on a T2 image. You typically wouldn't see anything on a T1 image, but it's critical to be able to look at a diffusion-weighted image for full clinical diagnosis. The other type of sequence that is often run is called an angiogram. In other words, we're going to try and get signal just from vessels where blood is flowing. In this case, we're going to look at the arteries. So if you remember, the signal intensity from our gradient echo sequence had terms in proton density and T1 and alpha, etc. Now, what happens when we're looking at molecules that are flowing here is that if you imagine the imaging slice on the left, we tip our spins down and we wait a certain time TR, and there is T1 relaxation that occurs. And then we tip them down again, etc., and we go through our imaging sequence. But the difference here is that if you have blood flowing through that imaging slice, then during that time TR, the spins that are relaxing have actually flown out of the slice, and you have new spins that have flown into that slice, and they haven't seen the RF pulse. So effectively, they come up with maximum magnetization. And so what that means is the effective T1 is very, very short. So our signal intensity, if we run a T1 weighted sequence, is going to be very bright coming from those vessels, whereas the background signal, which just stays there from the tissue, is going to be relatively low. And so we can write down an equation again. I'll leave this for you to look at your leisure in terms of the effective T1, which depends upon how thick that slice is on the left-hand side and the velocity at which the blood is flowing through. But we can see that the higher the V there, then we're going to get the shorter the effective T1. And so what that means is that if we do not the conventional way, which is if we go fast with a relatively low TR, we will want to take a low tip angle to get a good signal intensity. So if we look at the stationary tissue, we might want a tip angle of 10 degrees here. If we're looking at blood, which has a very fast velocity, we can use a tip angle of 80 or 90 degrees because the effective T1 due to inflow is very, very small. And notice the signal intensity difference between blood and stationary tissue is maximum then at higher tip angles. So very simply, a time of flight, as it's called angiography sequence, uses a gradient echo with a short TR and a relatively high alpha. And what happens here is if we look at the individual slices on the left, you can see that the vessels in each slice appear much brighter than the background signal. Now, if we take all of the slices together and we do a process called the maximum intensity projection, which is basically looking through all the voxels to find out where is the maximum intensity, and then rotating and rotating and rotating through to get a three-dimensional view, what we end up with is the angiogram on the right-hand side. So this is no contrast agent. This is purely looking at the higher signal intensity due to the fact that blood is flowing while we're imaging. And so here we can form something where you see the background signal of the brain very low, and we can pick out very nicely the arteries in this case. And we can do similar types of sequences with different gradients and different RF pulses if we wanted to look at the venous system. So in conclusion then, if we use different combinations of RF pulses and gradients, we can produce these images which can encode lots of different parameters, relaxation parameters, physiological parameters, such as flow, such as diffusion, and there are many, many, many other examples of which can be, if you look at some of the textbooks, you see 20, 30, 40 different kinds of sequences. And the important thing is that we need to be able to relate these contrasts to healthy and disease pathology In other words, if we look at diffusion, what happens to water mobility? What happens to proton density? If we look at a necrotic tumor, there just isn't as much tissue there, so the proton density goes down. Sometimes in fatty liver, we're going to see fat content go up and infiltrate. In neurodegeneration, we may see changes in iron concentration, etc. So knowing those kind of physiological effects, knowing what effects those have on the MR parameters, we can then decide what kind of sequences to run and with what parameters to give us the maximum image contrast.
Thank you very much, Professor Webb, for that excellent presentation. I'm sure there'll be questions in the chat box. And if you have questions, you can raise your hands up and we'll call on you. Professor Webb is online to answer all your questions. Questions on MRI techniques
Thank you
and
so much. Thank you so much, Professor Webb. Thank you so much for that excellent lecture. And I'm sure before other people start asking their questions or putting them in the chat, I just have a quick question. Well, also this has to do with understanding, SWI and its ability to detect, iron content and calcium. Is there a way, technically, these are not clinical application question, because sometimes do we have other sequences that can help us to be able to differentiate between calcium and iron content in terms of using things like SWI?
Yeah, I think if you, it's a very good question. I think you have to use slightly more sophisticated sequences than are usually on standard on the scanner, right? But if you look at multi-echo, gradient echoes, and you look at how that signal decays as a function of time, then there are ways of getting exactly differentiating between iron and calcium and myelin and things like that. I think it's something that's not standardly done on a clinical machine, but it's certainly possible to do. So I think it's more in the processing of the data that you can acquire the multi-echo, gradient echo, but the processing to differentiate is a little bit more complicated.
More complicated, I guess as much. So we clinicians, most times when we are confused in that sense, we just go back and do a CT, and which
Yes,
is,
that's right. Yes, exactly. It's a very good way of seeing calcium, right?
very good way of calcium. Yeah. Thank you so much. I think we'll have other questions.
Yeah, so there's a question here that comes in from Kudirat, who asks where does MP range fall in terms of pulse sequence and gradient echo, and does it have applications beyond the brain? I've only ever seen it in the brain, and it's typically used, at higher field strengths. It seems to be not necessarily one of the standard clinical scans, either MP range or MP range 2. Although I have to admit, we quite like it for just really, really good white matter, gray matter contrast. So yeah, it's not standardly used, I think, but I think it could be better used, because typically if we have a non-contrast enhanced T1, then we tend to prefer an MP range. I think I sent everyone to sleep. That's okay. It's the middle of the morning.
Shola, do we have other questions? Okay.
Okay, Tony. So does balanced SSFP have any applications for brain imaging? I think it potentially does. It's some people use it, for functional imaging as opposed to, say, let's say, clinical imaging. I think, as you know, the issue is always whether you get a certain amount of banding coming in there. And I think clinicians in general are not very used to the contrast, right? The white matter, gray matter, or pathology in terms of the contrast. So typically it isn't used, but in certain centers, it's obviously a very high signal to noise technique. I mean, the highest that you can do. And so in certain centers, I think you start to see it being used, but it's more in research centers, let's say, than in clinical centers. So obviously, balanced SSFP in the heart is absolutely standard.
Okay. Thank you so much, Professor Webb. I think I just want to spin off a little bit to just get a stimulatory question out there. I know we have a lot of clinicians and there's a lot of physics in your lecture, but I just want to say, there's this idea about synthetic imaging. Is it in the future? Is it possible to have that you do just one sequence, or you do one sequence and you can be able to get other sequences from it, and so you can cut down on your imaging time and things like that? What's your thoughts about those kind of sequences? I know this is off the regular lecture topic, but just wanted to put that out there.
Absolutely. It's actually a question I would return maybe to the clinicians, because there has been synthetic MR, and you can even think about MR fingerprinting as another version of synthetic MR, where you can acquire the data very, very efficiently, and then you can synthesize T1 and T2 and things like this. And I guess the question is, from a clinical point of view, it has never really taken off. People don't particularly like it. And I guess the question is why? Is it that the contrasts you get out are slightly different? Because, of course, it's easy to synthesize T1 and T2, but then if you're doing 3D versus multi-slice sequences, you have different effects of magnetization transfer, for example, and that is going to change your contrast. So, theoretically, it's possible, but I know that clinically, very, very few sites use it. And actually, I think it's more a question for the radiologists as to why they don't.
Interesting, because I guess is what you know versus what you don't know. It's better to stick with what you know. I guess that's usually the key.
Yeah,
All
no,
right.
I think that's right, and I think radiologists do tend to be quite conservative because
Yeah.
they really want to know what they know with a
Yes.
very, very high level of confidence. So so I don't think there's a theoretical reason why not. You should be able to go much faster, but it is going to take some time to get into clinical practice.
Practice. All right. Thank you so much.
I know there's a couple of questions just came in about lower field. So one here says that there's open configuration touted for accessibility, but they sacrifice field strength or homogeneity. So is this trade-off worthwhile, or can you change your shims and gradient design to change the equation? You're absolutely right. Field strength, yes. If you're going to use permanent magnets and accessible magnets, the field strength is going to be much lower. You can get some of that signal to noise back, if you like, through the kind of AI denoising that we hear a lot about. The homogeneity is also quite a big issue, but I think you're right here that by changing your shim designs or making more sophisticated shims, you can actually get back to the situation where that inhomogeneity is not really affecting your image quality. Your image resolution is obviously slightly lower at lower field, but you definitely do need that extra shimming, because if you don't have that shimming, then you'll get lots of distortions and the images get a lot worse. And then another question from Magnus saying, if you're looking at ultra low field, which sequences can't you use? And do we have alternative sequences? So almost all the sequences you can use at low field. Some of the ones that have very fast gradient switching may be the ones which are hardest. So EPI, so echoplanar imaging, for example, is quite difficult to do because you get some distortions from that inhomogeneity, but also our gradients are not cooled as they are on a clinical scanner. And so if you try and switch them very fast, you have potential for heating there. But we do have, quite nice alternatives. So because the power that we put in is so much less at low field, then we can really run turbo spin echoes or spin echoes with hundreds of echoes there. And we can use very short pulses, and we can always use 180-degree pulses. And we can also take advantage of the much shorter T1 so that we can scan faster. So there are a few sequences we can't use, and there's a few sequences that actually work in a way much better at lower field. But it's a really interesting topic, to explore what are the best sequences for different applications at really low field. So what advice would you give someone who wants to develop skills in MRI sequence development but doesn't have access to research MRI equipment to test their work? Are there tools you recommend? There are some simulation packages out there where you can essentially, put in your particular sequence that you've designed with your pulses and your gradients and things like that. And then it will go through like a block equation simulation, and it will show you what your images come out as. And those are quite useful if you really have no access. That's what you can do. If you are interested, we have a very open pulse sequence programming environment here, and so do a couple of other labs on the low field. So, you're always welcome to send us a sequence. We can try and code it up, and then we can try it out and give you feedback on that. How did it work?
Thank you, everyone. If there are no more questions, I think we just thank Professor Webb for an excellent time and for taking time to record the lecture and joining in and then answering the questions. We appreciate you and your support for Smart Africa Network.
No, pleasure. Nice to see so many people here.
Yes, thank you so much. So we're supposed to start our first break in about 10 minutes, but I guess you can start right away, and we will convey by 12 noon GMT. No, that will be, we'll convey in 40 minutes for the second session. Thank you, everyone. Don't forget to log back in if you are logging out, but if you want to stay, you can stay.
All right, thank you. Let's take a break. And Shola, I think you can play some music while we are having the break. So,
Yes, we'll play some music.
So, yeah, some of us can go take a cup of coffee or take pap and akara while we wait for the next session. Thank you so much.
Hello, everyone. It's an absolute pleasure and an honor to be talking to you all about building your first low-field MR imager. Before I get started, I'd like to thank Professor Godwin for this opportunity, and at the same time congratulate him for keeping this platform so active and exciting. Now let's get started. A couple of disclosures out of the way. Here's what I would like to talk to you about today. Briefly talk to you about why we see this need for low field MRI. Give you a quick context before jumping into one particular design, just to make sure that we capture the global resurgence, the engineering that's involved in putting a system together, a quick one slider on challenges, and some conclusions. There have been 7 Nobel Prizes related to MRI, but did you know that 66% of the world does not have access to MRI? We reviewed the distribution of MR scanners globally and found that the geographies with the highest populations also have some of the least scanner densities. Of course, Africa, like you can see, is included at the very beginning of this graph, which means this is something that would be highly relevant to make sure that MRI is accessible in Africa. We did do a deep dive of this analysis and compared it to 5 different dimensions of access that you can see right on your right in this slide. And consistently what we figure is that the penetration of MRI technology in geographies with high population densities is critical for good healthcare. Back home here in the United States, although one might think it is different, in rural areas towards the western part of United States, you can see these hotspots on the left, which are called as radiology deserts. On the right, you see that these radiology deserts have an impact on the outcome of cancer patients, meaning the less prevalent these medical imaging devices, such as the magnetic resonance imaging system, are available, the less fruitful is the outcome for patients with cancer in this case. And this has been summarized in these 2 statements that I've highlighted from the Radiological Society of North America. We've been thinking about why access to MRI is so challenging and bucketed it into 2 different barriers. MRI. Give you a quick context before jumping into one particular design, just to make sure that we capture the global resurgence, the engineering that's involved in putting a system together, a quick one slider on challenges, and some conclusions. There have been 7 Nobel Prizes related to MRI, but did you know that 66% of the world does not have access to MRI? We reviewed the distribution of MR scanners globally and found that the geographies with the highest populations also have some of the least scanner densities. Of course, Africa, like you can see, is included at the very beginning of this graph, which means this is something that would be highly relevant to make sure that MRI is accessible in Africa. We did do a deep dive of this analysis and compared it to 5 different dimensions of access that you can see right on your right in this slide. And consistently what we figure is that the penetration of MRI technology in geographies with high population densities is critical for good health care. Back home here in the United States, although one might think it is different, in rural areas towards the western part of United States, you can see these hotspots on the left, which are called as radiology deserts. On the right, you see that these radiology deserts have an impact on the outcome of cancer patients, meaning the less prevalent these medical imaging devices, such as the magnetic resonance imaging system, are available, the less fruitful is the outcome for patients with cancer in this case. And this has been summarized in these 2 statements that I've highlighted from the Radiological Society of North America. We've been thinking about why access to MRI is so challenging and bucketed it into 2 different barriers. One is related to the system, which is expensive, requires sophisticated engineering, requires expensive siting, is a power guzzler, and compared to some other whole body imaging modalities like computed tomography or PET, is relatively slower. On the other hand, you also need a team of diverse experts to make this work, such as a good MR technician, MR physicist, a radiologic nurse, and the radiologist, of course. For the purposes of this talk, we will focus on the scanner. Now I want to touch briefly upon the recent resurgence of low-field MRI. And the main motivator for most of this renaissance is the cost of the superconducting magnet, which is about 38% of the total MR scanner. Roughly, a scanner is about $1 million a Tesla, so about a 3 Tesla is about $3 million for just the system, and the rest of it, of course, adds on to it with the service cost and the annual maintenance and things like that. Now, beyond the specific cost of the system, this superconducting magnet also requires high maintenance in terms of making sure that it's mechanically stable. At the same time, also the cryogenics are taken care of. So as an alternate, now there have been multiple approaches depending upon the field strength, or B0, in terms of approaches. These include the ultra low field permanent magnets, some of which that we're going to talk about today, specialty magnets which are more anatomy specific and could be resistive of superconducting, and then also these conduction cooled magnets that significantly reduce the use of cryogens in MRI. The ultra low field permanent magnet systems, which is going to be the focus of the rest of the talk, suffer from prolonged scan times because of the low SNR and also the reduced image quality. These are areas of active research in the MR community today. Here are some clinical use cases of low field MRI. Given my lab's focus on brain imaging, I've picked out only cases related to neuroimaging. So looking at 0.36 Tesla for use of for in the context of ischemic stroke, brain tumor imaging at 64 millitesla. Similarly, looking at intracerebral hemorrhage or trauma. Another application that we are equally interested in is the brain development and tracking of brain changes using morphometry and volumetry, using low field strengths. Here's a quick non-comprehensive view of the evolution of low field MRI. We have to remember that we are all inside this giant, very low field magnet called the Earth. But if you pick 2004 as one of these seminal time points with a PNS paper from the University of California at Berkeley, showing the images of these bell peppers at 132 microtesla, and then 10 years post, you see a book come out from the folks in New Mexico, at the same time from Matt Rosen's lab and others, putting together this wonderful machine of the hyperfine, and Clarissa Cooley and others from Professor Larry Wald's group building this Hallbach array with a rotating mechanism to image in highly homogeneous fields. Then you can see Larry at the top right talking to us about his magnetic particle imaging system while we were building an earth field scanner back home. In 2019, we had the first accessible MRI workshop in India. At the same time, Andrew Webb, Professor Andrew Webb, and his student Tom O'Reilly were putting together the Hallbach array, and Professor Wu and his colleagues were building the 0.055 Tesla permanent magnet system at the top. In Uganda, and this is a very significant contribution from Africa, you can see Professor Jones, Professor Godwin, Ivan, who's now in my lab, all of them put together this Hallbach, replicating Professor Andrew Webb's lab's design, and then you can see the MRI for All hackathon that we had a couple of years ago in New York, where we put together a system from scratch, which is a Hallbach array. You see this very nice innovation on the H magnet type, the Chinese Academy of Sciences, where they tried removing the pole piece for reduction in weight and produced that brain image on the right. So it's been a journey of about 20 years if you pick 2004 as the starting point. At Hopkins, my lab focuses on 4 areas related to accessible MRI. We develop low field MR systems and methods and try to disseminate most of these tools in an open source manner for wider use. We apply some of these tools to pediatric brain tumor imaging and high consequence pathogen imaging. Today's talk, though, will focus on the intersection between the open source tools and low field MR systems, focus areas for the lab. The goal is to address critical needs related to MR system and method development, and we have outlined some accessible MRI requirements, such as a system that needs to be developed needs to be compact, lightweight, no helium, should produce images of clinical quality, and should be easy to operate. In the lab, we focus on full stack development, and hence the DIY MRI is a good example of the full stack development. When you consider some of these design criteria, you end up with innovative MR scanner designs like the ones that you're seeing. The one on the left resembles a similar scanner design from the Minnesota group, for the 1.5T neuroimager. And one on the right could be a breast scanner for detecting malignancies. So how do you get started? One way that we've realized to hit the ground running is to do an open source, do-it-yourself way to build an MR scanner. And the QR code there can take you to the website for all the resources you might need. And we've looked at multiple options for approach, and I will tell you how we ended up with what we picked. Broadly, you can categorize the MR system into these 5 main components. The console, which is essentially the user interface and the way to interact and build software to talk to a spectrometer, which is essentially a way to inform the digital signals to the amplifiers via a digital to analog circuit board, or have some of this DAC or digital to analog boards on the amplifiers themselves. And then you have the RF coil and the magnet. The first 3 components, if you're at low field, are more or less similar, or you could reuse these components if you are within a range of magnetic field strength. The RF coil component has been significantly looked at, reviewed, and innovated even within the academic labs, and then you have a rich body of knowledge to design these coils. It is the magnet and the gradient that generally require ideation, thinking, and also focusing on what kind of patient population and anatomy that you're considering, and what is the specific set of MR contrasts that you might want to use in that protocol. And while people have been able to show some interesting output on performing functional MRI or functional MRI surrogates at low field, also recent diffusion weighted and diffusion tractography outcomes at low field, structural imaging appears to be the first set of tools that is generally looked at low field. You also need to estimate the R&D effort in making all of this happen and the potential of translating a system like this to the clinic. The control and data flow of these components is in a closed loop manner because, as we were talking, you program the user interface and the backend with pulse sequence programs that generate, if you're using open source, a .seq file format that then goes to a spectrometer that understands this file and produces, let's say, digital to analog waveforms, and in some cases maybe digital outputs that the amplifiers can then have DAC boards to convert to analog waveforms. These amplifiers amplify the voltages and currents and then supply the current waveforms to the gradient coil and the RF coils. And once the wonderful phenomena of MRI takes place with the imaging, then at the back end you receive the EMF from the RF coil that then gets amplified and sent back to the spectrometer, which digitizes the signal and then shares it with the console in terms of raw data or K-space for image reconstruction. Now, one less spoken topic is the economic feasibility of a prototype like this. Although it's a DIY MRI system, one needs to pay attention in terms of making sure that you have certain guardrails. And a general set of guardrails based on cursory market research suggests that such systems need to be benchmarked at the price of a new high-end ultrasound machine and should be significantly lesser than a refurbished MR scanner. Generally, this would mean about 100K USD for it to be feasible, and then you pile on the service contracts and the software packages which are additional. And now we get into the engineering parts of making this MR scanner. And here I'd like to talk to you about the tale of two builds. One on the left, which is our MRI for all hackathon, and one on the right, which started out from the tabletop scanner from Larry Wald's group, which Ivan and I significantly changed the hardware and the software components to it while still reusing the amplifiers and the gradient filters. And of course, some of the open source software that we've produced was also used and tested on the Uganda build in Professor Jones's lab at Mbarara. So the console comprises of software made mostly from Python, which is PyQt, and the backend is also Python with a bunch of IPC calls. And the pulse sequences that are listed here, we'll go into a little bit of depth of how to build those pulse sequences as well. But what you're seeing here are the real estate layout for how the top panel is dedicated to images, and then the bottom left you have the sequences. This is very similar to what you would see on one of the or multiple commercial vendors with MRI scanners. So the idea is to have people also use this for education and training, so it is similar to the one that they would eventually practice. The data acquisition module is actually a spectrometer. You can see the form factor of that very close to hand, called the Redpitaya 122 for the clock frequency of 122 megahertz. It has two transmit and receive channels. It bit streams, and then it's compatible with a tool that we've worked on in our lab called PyPulseSeq, which is the Python version of the PulseSeq tool from Maxim Zaitsev at Freiburg. And that tool helps us communicate with the Redpitaya board through an interpreter called the Flowcra PulseSeq interpreter, which I spent quite some time refactoring over the last summer for a workshop that we did. And Flowcra stands for Flow-Based Okra, which is open source console for real-time acquisition. Now, let me give you a quick overview on open source pulse sequence programming, why you would like to do it, and what are the benefits, and how you can access some of these things yourself so that you could get started with your first pulse sequence program today. Generally, when pulse sequence developers program on vendor integrated development environments and methods, they spend a significant amount of time developing the sequence on a particular platform, say platform A, and that is shown by an hourglass on the left here. But when the same sequence needs to be ported to a platform B within the same vendor, then you spend some time on it. But when the pulse sequence program needs to be moved and used on another vendor platform altogether, the time and effort required in quote-unquote porting or translating the sequence is considerable. That can be seen in this hourglass shown in red. On the other hand, if one uses open source pulse sequence programs shown in this icon here with an unlock symbol, then you can send the same seq files to the other vendors and play the identical waveforms as well. The caveat being you need to have an interpreter or a sequence that is native to that vendor but can read these seq files. Let me explain to you what I mean by this in a little detail in the coming slides. What has been accomplished though using PyPulseSeq has been the across magnetic field strength from a very low magnetic field strength all the way to 70. People have been able to demonstrate the use of PIPL-Seq across different vendors, including the scanner that I'm going to show you now, the MRI for all scanner, the multi-wave magnetic Q scanner 47 millitesla, which is based off Professor Andrew Webb's team's design, and over a host of different applications that are listed here. The list is of course not complete, as you can see. Here's a quick demo of how one would use PIPL-Seq to implement their pulse sequence on a vendor platform. Supposing a bunch of people met and had an idea related to developing a new sequence or implementing an existing sequence from a publication, or even the standard sequences like a gradient tree called ECHO, you would sit down and you would program in one of many tools such as a Google Colab or even ChatGPT. I'll show you some of that too, and then move the output, which is a seq file, into what is known as seq to vendor specific files. In the case of one of the vendors, it was mod files, and then you have an interpreter sequence sitting on that particular scanner, which can then do the acquisition for you, provide the raw data, and you can decide to reconstruct either inline or out offline away from the scanner console. Now, using that at 3 Tesla, using this framework, we've also been able to demonstrate that you can produce images very similar
Apologies. We completely apologize for the technical glitch. Internet keeps going on and off, even with multiple backups. So I'll pause. I'll play the video from where we pause, and then back it up a few minutes. Thank you for your understanding.
So how does PIPLE-seq work? Let's consider a very small example of a spin echo, which has straight that you can produce images very similar to vendor supplied sequences. What you want to do is to compare A and B for T1 and D and E for T2, and the differences, as you can see, are mostly scaling of intensities. All of those are available in these publications, the details. We also looked at quantitative imaging using open source pulse sequence programming. Here is an example of T1 and T2 mapping using a phantom called the ISMRM NIST phantom, and you can see that the two methods of the vendor supplied and the PIPLE-seq generated are similar. More recently, we have explored a 6-site demonstration of PIPLE-seq across different field strengths and vendors, and you can see that these different phantoms with different centers have all been able to use PIPLE-seq and generate images based on this open source pulse sequence programming tool. There are also another standard using the open source pulse sequence programming, a tool called Gamma Star was also involved in this study. So how does PIPLE-seq work? Let's consider a very small example of a spin echo, which has these different events playing out, like an RF event or a gradient event or an ADC and so on. What you do is you break them up into blocks of time, and each block might have multiple events such as an RF or a gradient and an ADC and so on. And then each event, which is let's say an RF event, has a shape associated with it. So you go block, event, and shape. So how do you get started writing your own open source pulse sequence program? Well, it's actually not that hard. With PIPLE-seq, all you need is a browser and a Google account. Then you can access Google Colab, and then, as you can see here on the screenshot, put together a bunch of code snippets, and you can download your first seq file. There are other things as well the open source nature of PIPLE-seq allows, and that is to explore and exploit the availability of large language models like ChatGPT. You can ask ChatGPT to now design PIPLE-seq pulse sequences at 1 mm resolution or time constraints. And here's an example where I asked it to design a gradient recalled echo sequence using the PIPLE-seq library for certain target specifications. And you can see that it's generating the code and also providing you some explanation, and then you can download the seq file and play that. Now, jumping to the other side of the story, which is the hardware, and here's the magnet design. Our magnet design is an H-type compared to what most groups have been doing, which is the Hallback array. And the reason for this is that you can actually achieve a higher magnetic field strength at the cost of a lower diameter spherical volume, or the target area within which you want a homogeneous magnetic field that you can see in the center figure B with the green circle. Of course, the forces are high, like most of these scanners, because higher magnetic field strength, higher the force, and this requires a lot of consideration with respect to safety that needs to be thought out before embarking on such a design. So here's how we did it. We started looking at YouTube videos on how they would combine monster magnets, and Ivan here put together this wooden jig, and one fine day we sat down to combining the magnets, and at the bottom right we were able to combine 3 magnets, each of diameter 6 inch, thickness 1 inch, so that's 3 inches at the top, 3 inches at the bottom, and this produced a magnetic field strength of 0.27 Tesla. To characterize the magnetic field, you need a field mapping robot. We've detailed the construction and the use of this field mapping robot in the reference below, but essentially it's run by a Raspberry Pi with open source code, which is all put up on GitHub, and a bunch of aluminium profiles and servo motors. What you see on the right is that we used to characterize the Hallbach scanner in our lab, and we could characterize up to 4 probes simultaneously, one for magnetic field strength and the other 3 for temperature, because we understand that there is an effect of thermal drift with these permanent magnets. We've also characterized the spatial accuracy of this robot using multiple measurements of making it punch holes and comparing that to a ruler, and at the same time showing the relative size to an American US quarter on the top. Further characterizations also include the effect of noise while the robot probe is moving, and vibrations and acceleration during the probe movement as well at the bottom right. Here's an interesting plot, which is we did these multiple trials of leaving the probe in one single point and looking at the stability of the magnet and the magnetic field strength over time. On the left, what you see is for the Hallbach scanner that we had characterized that it's relatively stable at the magnetic field strength about 47 to 48 millitesla. Whereas on the right, you can see that even though there has been a change in temperature for more than 1.5 degrees Celsius, the magnetic field strength is relatively stable at the center of the magnet, which is where we wanted to measure this magnetic field stability experiment data from. So in general, the idea is to have a tool like the field mapping robot that can characterize your magnetic field. Once you do, you end up with the plot in A for our magnet that we built. And you can see that there are hot spots at the top and bottom because of the 2 pole pieces of the magnet being the top and the bottom. But then what you want is a more homogeneous field. To that end, what you need to do is passively shim the magnets, which is another way of saying making the magnetic field more homogeneous. This can be done by a bunch of small tiny magnets. In our case, we looked at magnet combinations of 1/4 inch in each dimension of a cube, and then coded up a genetic algorithm that essentially produced the magnetic field that you see in C, which is complementary to A. And in your mind's eye, if you can add A plus C, that should look more or less like D, which is our simulated target. And after simulation and making the passive shim magnets that you see in F, we did get the field again measured using the magnetic field robot that you see in E, which is similar to D and is more homogeneous than either A or C. That kind of also makes sense in terms of the output of the genetic algorithm, where you see at the edges, you see magnetic field strength pointing up. For us, north was positive, which is up was positive, and it's adding magnetic field strength on the sides, whereas at the center, it's trying to reduce the magnetic field, so the net effect is a homogeneous magnetic field. The optimization function for this genetic algorithm was to reduce the range of the magnetic field, which is in the numerator, while increasing the mean magnetic field, which is in the denominator. So it is basically minimizing this ratio of the range of the magnetic field to its mean. All of this code is available on our website for the Delta DIY MRI. On the gradient coils, which is the next set of engineering tasks other than the magnet and the shimming, is to have a design field. The magnetic gradient coil, magnetic gradient field strength coil, essentially has a linear variation in magnetic field along a particular dimension, and based on this you would like to come up with either wire patterns or coils that produce this magnetic field when you supply some current. And this is with the Biot-Savart law. What you do is you want to identify current densities that produce this kind of magnetic field strength, and if you treat these current densities as contours, which they look on the right, you want to optimize picking the right contours at the right levels so that you can actually produce the magnetic field strength of your target. Once you produce those contours, you can convert them into wire patterns, and then you can link these wire patterns to each other to make a winding coil, and then you kind of validate the simulation to see if you meet the target specification. In this case, what you want to homogenize is reduce the distance or reduce the error between the target magnetic field and the obtained magnetic field, while make as a percentage of the target magnetic field, which kind of translates into percentage nonlinearity. And the general threshold for nonlinearity in gradient coils is 5%. Then the last set of coils that you design is the RF coil. Although in the order of building a system, you'd probably do the magnet, the shims, the RF coils, and then do the gradients so that you can actually verify the RF like you can see in the picture below, and then go back to imaging. The RF coil is a simple 3 centimeters in diameters and about 3 to 4 centimeters in length, and then we put that into the scanner, and what you're seeing on the console is outputs of the RF spin echo showing that we do get MR signal. The resonant frequency was about 11.5 megahertz, and with a bandwidth of 100 kilohertz. The solenoid coil was 3 centimeters in length, 6 centimeters in length, 3 centimeters in diameter, had 30 turns, and the matching capacitance was 18 picofarad, and tuning, matching capacitance was 1.8 picofarad, and the tuning capacitance was 18 picofarad. After the integration of the entire system, you would then start collecting an image. Here's our two-step approach to obtaining an image. One of our first sequences was to obtain the 1D spin echo so that you could verify the functioning of the gradient, and you can see those in the plots B and D. And once those seem to work, then we did the 2D spin echo, where you can see the K-space at the top and an image with artifact at the bottom. And this is because of the eddy currents, because our gradients are not shielded. And you can see in A, the phantom that Ivan put together, which was a sphere, but chopped at the top and bottom so that it could actually fit onto the case at the same time, not be obstructing the RF coil. So that's our first low quality image. Briefly, I'd also like to talk to you about the challenges and then look at conclusion. In our build, we did not build the amplifiers, mostly out of a concern for safety. And given that we already had some open source amplifiers from Professor Larry Wald's group, Then from scratch builds are challenging to debug because you have hardware and software sources for error and interfaces and environments. So it's important to follow a step-by-step approach. And from the first image to a meaningful image quality generally requires good system characterization such as pre-scan pulse sequences and the like. And finally, simulations are necessary but are not sufficient. So multiple iterations and characterizations are expected and are necessary. In conclusion, I want to leave you with some of the highlights of a recent workshop we did so that I could convince you that this is something that is doable in academic laboratories and lab scale. We had a 3-day workshop where we focused on 3 things: was to learn from experts, spend a lot of time building, and also scan at the end of it. And here's our output of building and scanning. And this was limited to about 16-20 people who came together at Hopkins and acquired our first image. So we disassembled the scanner we built before the workshop and built it again from scratch in 3 days. Here are some testimonials and feedback that I won't bore you with, but to highlight the fact that students really enjoy this kind of experience, and it's interesting to see a system level learning that's possible in a short span of time. With that, I'd like to conclude that you can build complete low field MR scanners in academic laboratories in a short span of time. We do provide all the source code and design components on the website that you can see there. And the subsystems and target design specifications were met. Of course, we want to move the image quality to much higher and much better, and that's a work in progress. Quick shout out for our next year workshop that's going to happen in September of next year. We have a fantastic lineup of speakers and mentors who will be working with the participants to put together another MR system in 3 days. So the journey towards acceptable image quality starts at the end of such workshops. With that, I'd like to acknowledge the wonderful team that we have at Hopkins. Ivan's the engineer. Ajay works on deep learning aspects of low field MR. Dr. Shravan, who is now in a different setting but contributed significantly to the development of HyPulseq, and all the wonderful collaborators from across the globe. And a special mention to Professor Ogbole and Professor Jones from Nigeria and Uganda respectively, and the funding sources that make all of this possible. With that, I'd like to close, and I'm happy to take any questions in the format that the organizers have. And here are my coordinates in case you need to reach out with any queries. Thank you very much for your time, and I look forward to answering your questions.
Thank you so much, Professor Syra. I think he's online here and he can answer our questions. Let me just confirm that in a bit.
I'm here.
Okay, yeah, he's there. So I'm going to start with the questions from the chat box. Then participants can then raise their hands and ask their questions. Chinisom Modebulu asked that what are the approval processes to make built MRI PSDS market fit? That's the first part of the question. The second part is, The mechanism you share, does it work for both low and high field? Professor Siram.
So thank you for your questions. Let me start off with the first one. The approval and accreditation processes generally are more involved. And as you can see, I have not touched upon that in this particular talk for the reason that the focus was to build a first-off scanner. Without going into the details, it's a multi-step approach that involves levels of data from the same scanner, such as those from phantoms, ex vivo, in vivo, and other clinical, preclinical animal models, at which point in the United States, you can apply with your local IRB for what is called as a non-significant risk device. And then there are higher levels of accreditation, including the commercial pathway in the United States for applying for what is known as a 510K or an FDA approval. But that is probably the details are more an offline topic, and I'm happy to chat more about our experiences with some of that. But in brief, it's a involved process. On the second question, of is it available also on the high field? I think with these changing definitions of low, ultra low, very low field, and high field, it's hard for me to answer that question in a very clear manner. What I will say is it is mostly dependent on two components, which are the amplifiers and the spectrometers. The spectrometer that I showed today, based on the Red Pitaya Marcos formulation, can go up to 50 megahertz in theory. So you want to be lesser than that. So I would say reliably, you probably could edge up to 1 Tesla, which is 42.58 megahertz. That is where I would leave that. It depends on these two components specifically, the spectrometers and the amplifiers. Of course, everything from there, the design changes, but those are the two key components that influence the rest in terms of the magnetic field strength.
Okay, thank you so much. Chinisom, I hope Professor Siram has answered your question. Other questions, please raise your hands and let me call on you if you have other questions for our speaker.
Yeah. Siram, thank you so much for that excellent talk. Very extensive talk, I must say. I must appreciate you. I put a question in the chat, and I just want to say that apart from the scanner that was assembled by Andrew Webb's team using the team in Uganda, and they did that in under 11 days. Do we have any other scenarios around the world in Europe or Asia where similar scanners have been assembled and have been tested? I know there was a team, I think, I heard about the team being put together in Cape Town and possibly also in Peru. Are we aware how many of these scanners, have been put together and have been used either for research and that you know about and that you would want to share if you have that knowledge? Secondly, you plan to put a scanner together in 3 days, working with mentors and mentees at your Johns Hopkins lab. Is this the first time this is being done? And how feasible is that? And do you have facility to invite people from resource poor regions to participate in this kind of a workshop? I see that it's been planned for September next year, and this is a long planning time. So it would be nice to know if there are resources or ways that we can get people from low resource centers to participate or at least get some level of exposure to see how they can also replicate this kind of feat in their settings. Thank you.
Professor Godwin, thank you very much for the question. And I would like to go in the order that you asked me. First, we are aware of 3 builds in general that have built hallmarks, all three hallmark arrays so far. One is, of course, the Uganda build that you so importantly spearheaded with Jones. And then the second was MRI for all, where five of us, including me, with the acquisition, Tobias Block, Lear, Alan, Jason Stockman, Clarissa, we all came together um, to do another hallmark in New York, and that's also published now. We did that over 5 days. And the third one was the Easy MRI recently at ISMRM in Singapore, where this happened in Sherman Wang's lab at SUTD, and they put together in, I think, 4 days plus. So these are the three builds that I'm aware of. I know in Germany they did try something earlier with MRI together. Um, the second question is about the 3-day workshop. We just finished the build pictures that you see, the images that you see on this talk are from an H type magnet that we did build during some time, but we rebuilt the whole thing during a 3-day workshop. So we've done this now, 5th, 6th, and 7th this year, the last couple of months, ago. We were able to build that scanner from scratch in 3 days. And one of the slides in this presentation talks about the testimonials from the students. The GitHub website link that I've shared at the very end also talks about the previous workshop. So based on the success of those 3-day workshop, we now want to expand that to a larger audience. We do have some funding from corporates already roped in for the next year's workshop. I would like to explore this with you offline to see what best we could do to support scientists from Africa to participate in this 3-day workshop. But yeah, so we've built this once, and now we're confident of repeating the same or similar kind of build again in 3 days.
Thank you.
Are there other questions from our participants? If you have questions concerning building MRI challenges, or if you're particularly keen on building one or working with people who are building one. Okay, I'm not seeing any hand. Okay, if there are no more questions, I would like to thank our speaker, Professor Sairam, for gracing us with his presence and taking time to put together this beautiful presentation, I must say. Thank you once again.
Thank you all. Thank you, Professor Godwin. Thank you, Adusola. Thank you, everybody.
Thank you. Thank you so much. Excellent presentation.
So we'll be going to our next presentation. It's going to be a live presentation. Let me confirm our speaker is here. Dr. Clenham. Yeah, she's here. So give you a brief overview, introduction for Dr. Clenham. Dr. Clenham is a consultant radiologist and a professor of radiology in Ghana. She was the former head of radiology at the Kulebo Teaching Hospital in Accra, and then she is currently the faculty chair of radiology for radiology, Ghana College of Physicians and Surgeons. She's the vice president of the Association of Radiologists in West Africa and president, Earth for the World in Ghana. She will be taking us through the topic MRI safety and all it entails, making sure that we, as much as the MRI is very useful, it can be very dangerous. She's going to be taking us through how we can safeguard ourselves and our patients. Thank you. So, Clenham, you
Yeah,
have
thank you. So, though I sent the earlier, I have I want to share. Can I share? I'm trying to share my screen, but it's not allowing. Okay.
beautiful. We can see, but not yet in the presentation mode. Yes, now in presentation mode.
Okay. So, good afternoon, everyone. I want to thank Mata, whose director is Prof. Wole and Adesola, and everyone for inviting me. Though the notice is just 48 hours notice, but, but I've accepted to do that. So I'm going to talk about MRI safety. And I know that the low field ones do not have all these problems that the high field ones have. So it's basically going to dwell on the high field MRI machines and the issues they cause. Yeah. So my objectives are we have to understand the biological effects of exposure to MRI fields and also to understand the safety issues of MRI. We'll look at introduction, biological effects of MRI, safety issues in MRI, conclusion, references. We know that the superconducting MRIs, they are the most common types that we have and are known for their strong magnetic fields, allowing for high quality images. And we also have open MRI machines and then the resistive MRI machines. The MRI scanner's main superconducting magnet is always switched on and very strong. So its strength is measured in Tesla, as we all know. The MRI machines used in clinical practice are usually 1.5 Tesla to 3 Tesla. And the 7 Tesla ones or higher ones are usually for research, unless they are being used now, but for clinical work, but I know they are mostly for research. And at least a 3 Tesla MR machine will produce a magnetic field of around 60 times, which is stronger than the Earth's own. In Ghana, we have a 3 Tesla machine in one of the hospitals. That's the highest we have in Ghana. So the strong static magnetic field in an MRI scanner is produced by a superconducting magnetic coil. And we know that this is placed on the very outside of the MRI machine and weighs several tons. Then we have the gradient coils and then the body coils. All these produce causes problems to patients in terms of MRI safety. Hence, I'm mentioning them. So we have the high static magnetic field, and then the gradient magnetic fields, and then the radio frequency magnetic fields. The risks generally arise from these 3 distinct mechanisms. Now, we have to consider some safety issues which is related to the strong static magnetic field. So we can have biological effects and also projectile hazards. We also have compatibility of implantable medical devices and also compatibility of peripheral equipment. All these cause safety issues. So what are the biological effects of static magnetic field? We can have sensations of nausea, vertigo, and metallic taste in subjects which are exposed to about 1.5 Tesla to 4 Tesla static magnetic fields. Some minor changes in the heart rates and the beats of patients can occur when they are in magnetic fields more than 8 Tesla. These are very high ones. Sometimes we could really have induction of ectopic heartbeats. So during an MR examination, the time-varying gradient magnetic fields are often switched on and off. So the biological response is based on the opportunity of gradient fields to induce electrical currents in any conductor, so-called eddy currents, and the ability of such biological tissues to act as a conductor. We know that the human body has several excellent conductors. We have nerves, muscles, and blood, and the biological effects are related to the changes in the magnetic field that induces these currents. Hence, the biological field effects of gradient fields, the most common phenomenon is the peripheral nerve stimulation, okay? This results in stimulation of nerves and muscles, and patients can have involuntary twitching, especially in those who are in the periphery of the ball, where the gradient variations are greatest. So peripheral nerve stimulation may cause discomfort to the patient, resulting in the patient moving in the scanner or possibly requesting the operator to stop the examination. So when you put a patient in the scanner in the MRI machine, you need to also be observing what is happening to the patient in the scanner. Other biological effects are time-varying magnetic fields, which will cause magnetic force fields that cause a flashing sensation in the eyes, that together with disturbance of eye and hand coordination could affect the optimal working performances of the staff executing delicate interventional MR procedures. So even the staff, especially interventional radiologists, could also have these flashing sensations in the eye due to the time-varying magnetic fields. So the time-varying magnetic fields can also produce acoustic noise, which can reach up to 140 decibels for some sequences. This noise can be, acoustic noise can be very, very disturbing to the patient. In MR systems, the partial distribution of radio frequency energy depends on the design of the transmitter coils, the frequency, and the shape, size, and tissue type of the image object. So the radio frequency fields also has some effects, like they have effects on several organs like the eye and the testes. And because the eyes and the testes cannot quickly respond to heating, mainly because of their very poor capillary network, they are under some increased risks of thermal injury from these radio frequency fields. So most of the reported accidents burns due to hot spots in the presence of conducting materials close to the patient, such as leads of equipment for monitoring physiological parameters like heart rate, blood pressure, oxygen saturation, and temperature. All these are the biological effects of radio frequency fields. This kind of risk can be more serious in the case of internal biomedical implants, like those who have aneurysms, clips, stents, and especially for implants that have elongated configurations and or electronically activated. That's when they have all these wires around the patient in the scanning. There are two main types of forces in the MR environment. We have the translation one, which is also called the missile effect or the projectile effect. That's the commonest that we are all aware of. And then we have the rotation or torque. This one is a rotational effect of implants within the body. So what are these projectile effects? We know the strong static magnetic field can attract ferromagnetic metal objects, which can act as projectiles, hence the name, and also called missile effects. So the strength of attraction is inversely proportional to the square of the distance, which means that the force quadruples at the object's distance from the ball is half. So the more you are close to it, yeah. So a ferromagnetic object can reach speeds of up to 45 miles per hour on its way into a 1.5 Tesla magnet. Such iron-containing metal objects can become so powerful projectiles and can cause serious injury or even death. So all equipment, regardless of its function, should be tested with a strong handheld magnet of at least 3,000 gauss before it is used in and around the MR scanner. So if the equipment is found safe after testing, it should be labeled as MR safe and used only in the MR suits. Hence, we have examples of handheld screening magnets, which can detect whether this equipment is MR safe or not. I picked these examples from the internet. This is another example that can detect ferromagnetic substances. This is another one too. They are all handheld ferromagnetic detectors for screening patients before they get in or other equipments. Apart from the handheld ones, we have these wall-mounted ones to which some MR suites have. So as soon as these are also metal detectors, as soon as you're approaching the MR entrance, which is zone 4, it will beep if the metals on you or what you are carrying is not safe. We also have this walk-through gates MR metal detectors. You can see they are movable. You can just mount them anywhere you want them to be, and patients should walk through it. And if they have an MR unsafe metals in them, this will beep, and this will be corrected. So with the projector effects, it's been there for some time now. And unfortunately, the first one that happened was in July 31st, 2001, when a 6-year-old boy died, unfortunately, after undergoing an MRI exam in a New York hospital. He was in a scanner, and some oxygen cylinder tank through the projector effects hit him in the scanner and crashed his head. Unfortunately, lost his life. As I said earlier, it was the first fatal MR accident reported. Kolebu Teaching Hospital, we also had our own share of this missile effect. Our machine was installed in 2006. The first MRI machine in Ghana was a Philips machine. And a patient came with the father in a wheelchair. And before the techs could realize, this guy was in front of the MR machine room, that's zone 4. And unfortunately, the door was open and the missile effect, through the old man's wheelchair into the scanner. It's not MR safe. Fortunately, he held onto the father, so he wasn't hurt. We have wheelchairs and structures that are MR safe that he should have been moved on, but nobody, the staff were not vigilant at the time, and then this incident happened. Later, we'll talk about the zoning effects, and that would prevent these things from happening. People will think that this missile effect is not a problem. It's still ongoing. I prescribe to this journal, and anytime they send me these articles. This was in February 2023. And the title gun goes off during MR, injuring patient's son. So this was a 40-year-old man who was accompanying his mother to the MR exam, and then the magnet caused his gun to fire, shooting him in the abdomen. This was, I think, in Brazil. What happened? He wasn't screened. There was, yeah. Meanwhile, all the safety issues are there. So we shouldn't take this thing lightly that we know, but we have to be vigilant and not forget when patients are around us and we are going to image patients. Another example was recent one I received October 1st, 2024. Yet another MR freak accident is making headlines months after it took place. This one, in what is being described as a freak accident, a patient in California narrowly missed serious harm inside an MRI suite. The incident occurred in an exam room while a patient was waiting to begin their scan. During that time, a trainee is said to have brought a wheelchair that was not MR safe into the room. So we have to be very, very vigilant with anybody who works around the MR unit. I'll give you another example. September 25th, 2024. This one, imaging center drag rate goes awry after corpse gun is sucked into MR scanner. So this happened in Los Angeles early. So during an attempted drag raid, police officers allegedly damaged an MRI machine after 8 high-powered magnet rips a rifle from an officer's person. They got into the facility. They said they were chasing, or according to the story, illegal people with marijuana and all that. And the people didn't take the precautions and the safety measures, and this was what happened. Then April 16, 2025, this year, MR projector accident likely to result in a 7-figure sum repair bill for hospital. Remember, when these things happen, the machine is also affected. When the Kolebu one happened, it took 6 months before we could start using the machine again. We had to invite people from Holland to come and quench all that, the machine, before we could start using the machine. So in this case too, the accident occurred last week, blah, 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 University Central in Finland, okay. When an employee entered the MRC to clean it, they were using a large piece of cleaning equipment, presumably a bathing machine, when it was sucked into the MR ball at a high rate of speed, according to local news outlets. This was this year, okay? And I want to tell you about my experience, but I was firm. During the COVID time, you know, you after each patient, you have to clean the place, all that, with equipment and all that. So the doctors were saying some patients have neuro COVID, so they should have MRI. And I was insisting that no COVID patient can enter the MRI machine, because if they enter, how do we clean? All the equipment that we've been using to clean the CT general, they are not MRC. So we cannot image COVID patients, and because we don't have the equipment that is MR safe for cleaning that machine in the place. So always we have to be alert about this projectile effect. It's still happening. It's still happening, despite all the knowledge about it. Okay. These are examples, and a pic also on the internet. It's a funny headline: MRI machine eats the bed. So the bed is not MR safe. They made a mistake, and then projectile missile effects. You can see this is the MR scanner, this is the bed. Yeah. In Kolebu Teaching Hospital, this is the stretcher, the wheelchair we have, and the stretcher. So at Zone 1, the patients are transferred onto this wheelchair, which is MRC, or the stretcher, if they cannot sit. And we have to be vigilant and insist on that. So special equipment has to be made for the MRI machines. Every center has it. Yeah, special wheelchairs, stretchers, monitors. We are going to have monitors. They have to be MR safe. Oxygen tanks should be safe. IV pumps. All these metals are made of either plastic, gold, sterling silver, or titanium. The second force is the torque force. These are all safety issues related to the static magnetic fields. The torque is a twisting force on objects, and it's greatest in the center of the ball, the magnet, where it can cause ferromagnetic implants and foreign bodies to align with the magnetic field. So the potential for an injury depends on the strength of the magnetic field the type and the location of the implant, size and orientation of the implant, and the length of time the implant has been in place. So the two greatest potential complications of implant-related talk are the eyes and the brain. Okay, so for instance, all patients with a history of metal-related eye injury and or sheet metal workers, which we have welders and all those people that do not have positive confirmation of the absence of intraocular metal should be screened with conventional x-rays before undergoing MR. We do it in our centers. If the patient has a history of that, when you do an x-ray, you can pick any fragments which can be in the orbit. Research has indicated that metal fragments too small to be seen on conventional radiographs, that's 0.1 millimeters, are too small to damage the ocular tissue. So the x-rays are good screening things if you suspect somebody to have a metal fragment. If you don't see it on the radiograph, then it means it's too small to cause damage to the ocular tissue in the MRI. Because of this talk, patients will always complete information about all implants before entering the room. In fact, every institution center has a screening form that is used for patients to give their history, whatever metals they have, whatever surgeries they've done, and all that. And we know that several deaths have been reported in patients with pacemakers who are not MR safe and who have undergone MR scanning without the appropriate precautions. So what are the non-ferrous metals? That's metals that are safe for MR use in the magnetic fields. Titanium is an expensive heavy metal, it's safe. Gold, silver, copper, brass, aluminum. They are all safe to go into the magnet. But you don't assume, always we have to check them, these handheld magnets, detectors, and others. Now, because of this static magnetic field effects, in 1997, the FDA Center for Devices and Radiological Health first proposed terms to be used to label MR information for medical devices. At first, it was just classified as MR safe or MR compatible. But in 2005, they changed it, or it was revised to MR safe, and then the metals or equipment MR safe. Is this MR conditional or is it MR unsafe? All these are labels that have been developed, classic labels developed to label things. For instance, if you have MR safe item, this item poses no known hazard in all MR environments. If you see the label MR safe. So it means items are non-conductive.
Can't hear you anymore, ma. I think she
Hello?
lost it. Hello, Professor Clenham.
Yes.
You stopped sharing.
Then is the internet, right?
Okay, you can.
Were you hearing me earlier?
Before, yes,
Yeah.
we were hearing up to like 45 seconds ago.
All right. So I'll share again. Sorry about that.
Yeah.
Is it okay?
Yes, yes, yes. I think this
Can you
is,
see my screen now?
you can see
Yeah.
your screen.
Yes,
Yes,
we
we
can
can
see.
see your screen. We can hear you too.
Okay, thank you. Okay. Yeah, you did you hear me about this one? So
Yes, yes.
okay, the MR safe, yeah.
Yeah.
This
You're
is
talking
the
about
icon.
the, yeah, you were talking about the elements.
Oh, okay. All right, okay. So yeah, here. Yeah, these are all safe: titanium, gold, silver, copper, brass, aluminum. They are all safe, but you cannot assume. You always have to detect them. I mean, using the handheld magnet before the getting, or the other examples that I showed you, wall mount detectors and all that. Yeah. Then this in 1997, it's developed that they should have a label for all this equipment that will be used in the MR facilities. So they were classified as MR safe or MR compatible. But in 2005, the terminology was revised to MR safe, MR conditional, and MR unsafe. So for the MR safe, if you see this icon, it's MR written in green on a white background with green borders. If you see it stuck on any equipment or metal, you know that this is MR safe device and it can enter the MR room. Okay, but always you have to, I mean, confirm by what? Using the detectors to check whether it's really safe. Yeah. And the second one is MR conditional. This is an item that has been demonstrated to pose no known hazards in a specified MR environment with specified conditions of use. So there should be some conditions which should be listed on the equipment, which will show that it's MR conditional and hence can be used. And this is the logo or the icon for a material that is MR conditional. It consists of a black inside. This is the black inside. MR is written in black on yellow background with a black border. Okay. Sometimes they can say that under the defined conditions, this is safe for using a 1.5 Tesla or safe in 500 Gauss magnetic fields or below. This is the conditions will be attached before it can be used. So you always have to read what conditions under which this one can be sent to the MR area. Then we have the still on labeling MR unsafe. It is an item that is known to pose hazard in all MR environments. So MR unsafe items include magnetic items, and is what's the icon is the black on a white background with this diagonal red band across it. This is MR unsafe. So this device can never get near any magnetic field. Okay. So these are the three types. We have MR safe, MR conditional, and MR unsafe. There are stickers that you see on some of the equipments and other items. And also, you should also post these stickers in the scanner so that even when people come and they see, they can know that what they are holding is not safe. They can look on it and look on the wall and say, this is MR unsafe, or this is MR conditional, or MR safe. So this is just a picture I took from a hospital in Michigan, one of the top hospitals. And you see the pediatric MR machine, so nice. The kids are hardly sedated before they enter. It's so fascinating. I hope one day we'll have this in Africa. And this is a CT scan, like a pool. Okay, so zoning. Earlier on, I was talking about zoning when I mentioned the MRI zone 4, patient just went straight to that area and cause that havoc to our machine. So we have 4 zones, okay, for safety issues. We have zone 1, zone 2, zone 3, zone 4. Zone 1 is the area which is freely accessible to the general public and typically is outside the MR environment itself. Here, patients are screened, everybody is there, healthcare, there's no, as I know, screening as such, but patients are screened from zone 1 before they get to zone 2. Zone 2 area is the interface between the publicly accessible and controlled zone 1 and then the strictly controlled zone 3 and 4. And then zone 3 is the use of any ferromagnetic objects equipment can result in serious injury or death. And then zone 4, this is a magnet room where the MR scanner is located. Zone 4 should also be demarcated and clearly marked because of the presence of very strong magnetic fields, and should be clearly marked with a red light and lighted signs stating the magnet is on and all that. It's really a restricted area. And this is just a summary of the zoning. We have picked this from American College of Radiology. You see, you have the zone 1 is the unrestricted area. Anyone is free to move about. You have the participant complete the MR screening form I talk about in zone 1. Then zone 2 is the restricted here. Zone 2 is the restricted card key access. All persons must be accompanied by safety trained personnel. Zone 3 consists of the scanner control rooms. 2 safety trained personnel must be available after normal working hours in some centers anyway. And then zone 4 consists of the MR scanner where the machine is. And every patient must complete the screening form before entering this section. So it's important that our hospitals, we try and do this zoning to be able to avoid some of these accidents. So at Kolebu, this is the entrance of the zone 4, where the machine is sitting. And this is the 1.5 Tesla MR machine. Now, some items can be damaged by the magnet. The list is endless, but this is just some examples. It's cell phones, watches, credit cards, bank credit cards, hearing aids, hair accessories, belt, buckles, shoes. Some shoes have metals in them, pocket knives, cigarette lighters, tie clips, and we have to add guns and all those things. They can be attracted to the magnet and even get damaged. Now let's talk about the other effects from all that we've talked about is from the static magnetic field. Now the gradient magnetic field, that's the time varying fields. They usually, as stated earlier, will cause acoustic noise. And we know that MR noise may cause a patient annoyance, anxiety, difficulties in verbal communication, distress, temporary hearing loss, and even potential permanent hearing problems. We all know that MRI produces a lot of noise as the current passes through the grading course. And also, as if you ever even done it before, you know that maybe when the sequences change, the noise even changes with them, and it can be very disturbing. How do we solve this acoustic noise? Usually, we have to, earplugs should be made available to everyone present in the imaging room during a scan, especially if noise levels exceed 94 decibels. We have commercially available earplugs that can reduce the noise level by as much as 20 decibels. So we shouldn't forget to give our patients these earplugs. We also have effects like a peripheral nerve stimulation, which I mentioned earlier. In cases of somebody having this, the patient should notify the operator and then the scan should be aborted. These are some of the safety measures. Sometimes we can also have heating of implants and other medical devices. So without a pathway to exit the body, the current builds up and the implants gets warm. So the degree of warming depends on the strength and rate of change of the magnetic field and the conductivity of the implants. We have military sharpeners, metal slivers, wires are all susceptible to heating. If these items are located in and around the eyes, spine, heart, or brain, on the brain, and they cannot feel anything. Tattoos and permanent cosmetics composed of. Can you hear me?
Yes, we can. Yes, we
Yes,
can.
we can hear you, ma'am.
Okay. Tattoos and permanent cosmetics composed of iron oxide or other metal-based pigments can cause reactions or adverse events, including first and second degree local burns. So those who do tattoos and some of these cosmetics can cause problems in MR imaging. And also we know that certain types of underclothing with antimicrobial silver microfiber, this may not pertain too much in Africa, but it's good to know, have also resulted in local burns. So the best safety practice to ask patients to change into a hospital supply gown. And this, one of my radiographers did, and I was very impressed. You know, I need to do an MRI, and I came with my own gown and all that. Gown which has nothing, I mean, I know it's safe, but this radiographer insisted that I change it to the hospital gown before the MRI is done. Okay, this is an example of MRI bend. I pick it from the internet from a patient during the MRI exam. We know that these are high field superconducting magnets we're using at the moment use helium. I know that there are newer ones now that are zero ball, no helium and all that. But what we have, most of the scanners we have here use helium. And we're going to talk about the quench of cryogen safety. So a quench happens when the magnets temperature rises above Earth's critical temperature, causing the coils to lose their superconductivity and develop resistance. We can also have heat generation. When resistance develops in the coils, the circulating current creates heat, leading to rapid evaporation of the liquid helium. So the rapid evaporation of the liquid helium causes a sudden explosive release of helium gas, which is then vented from the room through a quench pipe. And the rapid change in temperature and the release of helium gas disrupt the magnetic field, causing the MR machine to shut down, hence the loss of magnetic field. When our MR had that incident, the machine has to be quenched. At the time, we didn't know how to do it. Our techs didn't know. We had to call the Philly people from Holland to come and shut the machine, quench it before they could remove the full check. We also have emergency venting, which is properly designed MR rooms have emergency venting systems, including bursting discs and quench pipes to safely release the helium gas and prevent pressure buildup. So there should be a way to vent the helium out of the room. These are specially designed in the room when they are constructing the MR suits. So there are two types of MR quenches that can happen. The first quench occurs as a result of a disruption or problem with the MR's own magnetic system. And then the second is a deliberate quench in which the emergency magnetic stop button is pressed and the quench is activated. This was the second one they did. They did the emergency stop, and then they were able to remove that wheelchair. So what happens in the event of quench? the patient should be removed from the scan room as quickly as possible. Although not immediate, you could have asphyxiation occurring from breathing helium. And additionally, because of the extremely cold temperature of helium gas, the room could be so cold that patients can have frostbites, okay? And then the quench produces a marked increase in air pressure inside the scan room, which makes it difficult to open the scan room exit door immediately. So in the event of a large change in room pressure, patients can have ruptured eardrums. So every site should have a written policy establishing what to do in the event of a quench. And MR equipment, including the examination room and any other areas where the coolant may be stored, should be installed with an appropriate exhaust system to vent the gases to the outside in the event of a quench. As a precaution, in a case of quenching, an emergency evacuation procedure should be established and rehearsed, like how we also rehearse we do fire drill. The MR staff should have this emergency evacuation procedure, which they should know what to do when there is quench, okay? And then oxygen monitors with an alarm audible in the control room should be in the examination room and other areas where coolants are stored. So these oxygen monitors will be who they feel that the oxygen level in the room is getting low. It's recommended that emergency quench buttons be installed both inside and outside the examination room. This is just an image I picked from the internet, which is showing the quench situation where the helium is being released, and vented outside, from the equipment. Now, if we talk about safety issues, it's not only about this talk or missile effects and all that. We have to consider contrast agent safety too. And we know that gadolinium is the contrast medium used in imaging during MR, okay? And we can also have adverse reactions. They are usually minor, but we have to bear in mind that this can also occur. And we also should be exercised before administering contrast medium to lactating mothers, as some agents are excreted in breast milk. So when the women are lactating gadolinium, you have to be careful. And also some agents too can cross the amniotic fluid. So some will say pregnant women, maybe first, second trimester, no GAD. Some also say in pregnancy, no need to give gadolinium. And we also have to not forget to ask of history of allergy. Though we know gadolinium, they hardly react, but still that history has to be taken. And emergency trays should be ready with the steroids and antihistamines. But gadolinium has been known to cause this condition called nephrogenic systemic fibrosis. It has been established. It is seen only in patients with severely impaired renal function, okay? So if the patient has severe renal function and it's had gadolinium, this condition can occur. And it occurs several months or some years even after administration of gadolinium. And this is because they have renal impairment. Because of that, before gadolinium is given to patients, we also always have to insist that patients who have estimated GFR of less than 30 mils per minute should not be given gadolinium because of the possibility of developing nephrogenic systemic fibrosis. And what is this nephrogenic systemic fibrosis, this condition? Is characterized by increased tissue deposition of collagen, often resulting in thickening and tightening of the skin, predominantly of the distal extremities. It can also affect the trunk. There's fibrosis of all other parts of the body. It can affect the heart, lungs, kidneys, periphery, vasculature, and skeletal muscles. and it's progressive and can be fulminant in approximately 5% of cases and can even be associated with death. So the disease predominantly affects middle-aged patients with special predilection for patients with concurrent hepatic disease, as well as the severe renal impairment. So this is an image from the internet with the patient with this nephrogenic systemic fibrosis. You can see the photograph of this skin, this patient thickened with erythematous plaques. And then you see this very thick skin and with hyperpigmented plaques. And the CT scan is here post-contrast, showing this thickened skin due to nephrogenic systemic fibrosis, and this MRI image also showing this thickened skin and subcutaneous tissues due to nephrogenic systemic fibrosis. Because of this, patients that have severe renal impairment and they need imaging, it's planned that the patient, the appointment should be given such that if dialysis facilities are available, the imaging is done, then the patient is sent for dialysis immediately. And literature says that studies have shown that excretion rates of gadolinium could be about 78%, 96%, even 99% in the first to third hemodialysis sessions. So if the patient has end-stage or severe renal disease, GFR is far less than 30, it can still be booked, MRI can be done, and then if they have dialysis can be done just after the scan. Okay. Another safety issue is claustrophobia that we have to consider when we are imaging patients. These patients, it results when they cannot be in a restricted space inside the MR ball. They become anxious, and then some can even run out. And MRI, the duration is long, the noise and all that. And some of the patients that Dr. Me even describe the MR machine as a coffin. You say you put them in a coffin. So before they are imaged, you need to counsel them and ask them if they have this anxiety about staying in an enclosed space. I remember when they brought our first MRI machine, our chief radiographer then didn't know he was claustrophobic, and he opted to be used as this thing for the scanning. And as soon as he entered, he couldn't take it. He has to run out of the machine room. So it's there. Patients may not know, but we, the staff, have to bring them, inform them about this, whether they really have such anxieties about enclosed space. Now, how do we prepare the patients before they get into the scanner? And also, I know that each hospital has screening forms that they follow, okay? Yeah. So the patient should be instructed to wear loose, comfortable clothing without zippers, snaps, or buttons. Because yes, even if they change into their own thing, they will not carry anything from outside unknowingly into the scanner room. For most examinations, patients can wear elastic pants and a plain t-shirt. But in our settings, we insist that you wear the hospital gown. Female patients should wear a sports bra without hoops or wires. Any other type of bra should be removed before the patient enters the room. All accessories should be removed, rings, bracelets, watches, earrings, body piercings, all that. And then face and eye makeup should also be removed, as I said earlier. The gowns that we have should have loose fitting sleeves so that the technologists can check for watches and bracelets, even if the patient wears it, because sometimes the technician is not in there whilst the patient is wearing, okay, the hospital gowns. So after they are worn, the staff can put their hands in and check whether they remove the watches and bracelets and all that. And also these loose gowns will give access to the radiographer to be able to give injections like the contrast medium. So it's very, very important that we sew our gowns to that effect and the patients change into it. And above all hospital gowns, especially for this MRI, should not have pockets in them. They shouldn't have pockets for patients to unknowingly or mistakenly put their things inside. This is an example of the screening form we use at Kolebu. I know each institution has their own. We usually ask of any prior eye injury, any prior surgeries, any metal in your body, any pacemaker, new heart valve, or any other device. Are you on any medications and all that? Do you have allergies? Do you have a condition affecting your blood, anemia, all those things, kidney disease, liver, diabetes, and all those things, okay? And the females, could you be pregnant or not? All these are very important. Are you afraid of being in a small space? That's claustrophobia. Okay, these are just a few things that you should consider when you're doing the screening. So in conclusion, since the number of MR scanners is increasing in Africa, there's a growing need for understanding the biological effects of MRI and for maintaining the safety of the patient's family, the MR personnel, and the equipment. You could see the examples I gave you from those journals that even patients, family, everybody should be considered in MR safety. Not only patient and staff, but family also. And then the equipment itself, if we don't do it well, we damage our equipment. So while the effects of exposure to MR fields remain an active research area, clinical experience shows that MRI is a safe imaging modality and that most of the risks are preventable by obeying the safety guidelines. So now I will ask my audience questions as a teacher before we continue, because I have some time. Okay, so one of the biological effects of gradient fields is A, missile effect, B, peripheral nerve stimulation. Somebody can just unmute and tell me remove. Are you with me?
Yes, ma'am, Tima.
Uh-huh.
It's B.
Is B, peripheral nerve stimulation. Great. Yeah. What does the quench button do? A, causes an immediate increase in the magnetic field in the event of an emergency. B, starts the process of a new MR patient scan. C, only turns off all electrical power to the magnets. D, causes immediate collapse of the superconductive magnetic field in minutes. What does the quench button do? You can just unmute and tell.
D.
Sorry, D. Yeah, causes immediate collapse of the superconducting magnetic field in minutes. Great. So, which of the following is non-ferrous metals? Which of them are non-ferrous metals? A, titanium, B, gold, C, silver, D, copper, E, brass, F, aluminium. Which of them is?
I think all of them.
Yes. Oh, I listed them all are non-ferrous metals. But remember, you have to test them before they get near the magnets. Okay. Concerning zoning, American College of Radiology, ACL zone recommendations, what is Zone 4. A is the unrestricted area. Anyone is free to move about. You will have the participant complete the MR screening form in Zone 1. B consists of the MR scanner. MR screening form must be completed before entering. C is restricted to card key access. All persons must be accompanied by safety-trained personnel. D consists of the scanner control rooms. 2 safety-trained personnel must be available after normal working hours. So what is Zone 4?
It's B.
B
consists of MRI scanner. MRI screening form was completed before entering.
Great. Thank you so much. Yeah. Any questions?
Thank you so much for this very beautiful lecture and interactive session. Any question as regarding safety for our lecturer? You can raise your hand and I can call you, or you can type it in the chat box. Any safety related question? I'm thinking we understood all that was said then, if we don't have questions.
Yeah,
Okay.
I believe so.
Yeah, they are thanking you in the chat box. Thank you for your excellent presentation. Thank you, Professor Clenham, for putting this together in the short notice. I must appreciate you. And thank you to our audience who have stick to us so far to this point. We are supposed to have one lecture, then break, but our lecturer is unavoidably absent. He's supposed to talk to us about MRI installation and then maintenance. But engineer Ofere is unavoidably absent. So we will just drive straight into the next lecture by Dr. Esham Gafar. Then we won't take any break anymore because I'm sure most of us are also tired and all. So that we can do the next 2 lectures and then we can call it a day. So thank you, Professor Kleiner, once again for this beautiful presentation and giving us audience and accepting our invitation. We thank you so much. On behalf of Smarta, on behalf of Professor Bole and Dr. Joseph, I want to say thank you once again. So
My pleasure. Thank you too for inviting me.
Thank you, Ma. Without further ado, let me introduce our next speaker, Dr. Esham. So, Dr. Esham was a master's in public health from Harvard and is currently pursuing another master's in precision health at University of Chicago. He's a Fulbright scholar who is committed to advancing local, systematic, and sustainable innovation to address interdisciplinary health issues targeted to reduce inequality and develop next generation precision health tools for community oriented and target care in resource limited settings. Dr. Esham has experience in cancer management planning, prioritization at the national level, and is known for his ability to lead, build stakeholders coalition, and present recommendations across various sectors. Join me in welcoming our next speaker. So I'm going to share, he has sent us a pre-recorded video, which I'm going to share with us in a moment.
Hello, everyone. It's a pleasure and honor to be here speaking with all of you today. My name is Dr. Hisham Ghaffar. Today I'll be discussing precision health and imaging and how they can be used to be driving equity, particularly in the African context. The objectives of today's discussion will be to provide an introduction into what is precision health, provide some examples on its application and the discussions happening around precision health, discuss its impact on equity, particularly in the African context, and then develop some recommendations that we can apply either at our level in terms of practitioners or to be used to advocate with policymakers in the region. So to start off, what is precision health? Well, precision health is a new term relatively in medicine, and you'll find that there are different definitions and approaches to it. This is particularly the case since it is not a regulated term, so it does not have a strict legal definition. And here I have three examples of three leading institutions in the United States and how their definitions slightly differ from one another, but maybe complement each other also a bit. So Stanford looks at what the precision health approaches result in, so predicting, preventing, and curing disease. The CDC defines it in comparison to precision medicine, with precision medicine occurring in the clinic and precision health outside of the clinic, so it is defined by its location. UCLA looks at the inputs, so taking into consideration genes, environments, and lifestyles. And you can see they might complement one another, but they don't necessarily strongly overlap. So it's important to understand what we mean by precision healthcare when we are discussing this with a group, or if we are reading about it or engaging with it, particularly as it becomes more prominent and prevalent in our field. There are also other terms which are used almost interchangeably as synonyms for precision health, but they are not really the same. So there's personalized medicine, which was the oldest term and one of the most frequently used. And this has fallen a bit out of fashion, in particular because we do not really develop personalized medicine. We do not develop a new medical drug for the individual. We might develop personalized approaches, but not medicine. So this is thought to be a bit misleading of a term and has largely fallen out of favor. Precision medicine is, as discussed with the UCLA definition, with the CDC definition, is usually targeted therapies and care that is happening within the clinical setting. So precision medicine falls under the umbrella of precision health, defined by its location of being in the clinic. While targeted care is one of the earliest approaches and most commonly understood, such as the targeted therapies in the case of oncology, which focuses on a specific marker or maybe genetic component. Here, it's important to also emphasize that precision health does not necessarily mean a genetic component. It can be targeting based on phenotype or the use of digital health. It is an approach on efficiency. So here's the definition I like to use, developed by the University of Chicago's Institute of Precision and Population Health. And I favor it not only out of bias, but because I think it is the broadest and most comprehensive definition and has the strongest applicability in the real world. So it looks at the inputs, gene, behavior, and environment, as well as the outputs, so prediction, prevention, diagnosis, treatment, and management of diseases, and can occur inside and outside of the healthcare setting. So this is the definition I will be using as we go forward in this discussion. What are the principles of precision health? Well, precision health is a result of our times, so it's necessary that some of the key principles are a reflection of our modern principles. So there's greater emphasis on prevention and prediction, so being able to predict disease, who's going to get it, how bad is it, and how likely are they to respond to interventions or the different various interventions, as well as moving earlier in the care continuum towards prevention rather than waiting later in the care continuum where a person has developed disease or complication. It is personalized, and again here we are personalizing the approach or the management protocol rather than the actual medication itself. And of course, from the term, it is precise. So think of us moving away from more blunt instruments such as chemotherapy. It is person-centered, and this is a wonderful movement happening within the healthcare, is to move away the nucleus of medical care from the preferences of the physicians or institutions towards those of the actual person experiencing their healthcare and taking their perspective and delivering care that means most to them. Precision health, as we mentioned, is not just genetic, but includes digital aspects as well. But in all approaches, it takes a lot of data, can be very personal and private information being shared, and therefore we need participatory and co-producing mechanisms with the individuals taking part in precision healthcare research or receiving precision health, as well as the communities and policymakers who should be regulating them. So it is important that precision health is participatory and produces benefits to those contributing to it and to broader society. And of course, as with any research approach or new approach being used, it needs to be preeminent. It needs to be better than what's already existing. So what is the promise of precision health? Well, as we said, we're moving earlier in the continuum, so we want more robust prevention and earlier diagnosis. This means we are reducing the burden of the later stages, whether financial, clinical, or socioeconomic. So it's important that precision healthcare can have the greatest benefit for people who would have bigger complications in later stages of disease. It also has the potential to increase efficiency of research, particularly as it's able to go through several iterations much faster than we would through trial and error. So we're able to understand what is likely to work, but it also gives us an idea of what we need to address when we are doing research. So we're able to get targeted to see where we should be focusing and what's most likely to work. In clinical settings, as we get more information and touch points, these data will help us make better decisions to tailor treatment and management plans for patients. As we learn more about our patients and our physiology and our diseases, we are better able to educate the future generation of physicians to provide for a diverse population and create training opportunities that might differ from earlier generations as we create more data points. This is, again, one of the most common approaches is targeted pharmaceutical discovery to better target certain points in the disease mechanism pathway to allow for the drug to be more effective. And then, of course, as we are able to better target the vulnerable populations and improve the likelihood that our interventions are successful, applied on a large scale, this will improve population health and improve equity by addressing the most vulnerable and those at highest risk of disease. The role of artificial intelligence in precision health will be the focus of the discussion today rather than aspects such as genomics, just because this is most relevant to imaging scenarios. And here we want to make the distinction. Precision health is a unique approach. So as we discussed, this is how we approach patients. It is not a tool in and of itself. Artificial intelligence is a tool. So these are examples of different tools, and we will discuss some of them going forward in the presentation. And here we find radiology and imaging are at the frontier of artificial intelligence and precision health within the medical community. And the reasons for that are that radiology is very conducive to big data in general. The amount of information developed at hospitals by radiology departments is very large and happens at a rapid rate. So there's a large volume and velocity of information being developed for big data. The value, it is very valuable information. We're not just looking at an image. Every point of that image provides a great deal of information that can be used in for other bits of information. There's a variety in the amount and type of information being developed. So this could be the modality, so MRI, CT, ultrasound, or whatever, as well as the patient characteristics or demographics, as well as the diseases that are being scanned. And this provides us with a lot of data inputs to understand what is noise, what isn't, and a lot of information for us to analyze, which is very helpful when training models or developing any artificial intelligence. And then the veracity of the information. This is a highly regulated industry. So the accurate information. The formatting, even in situations where digitization might not be hospital-wide or country-wide, chances are the imaging department or radiology department is most likely to be digitized or at the frontier, and this makes it easier to use when developing artificial intelligence. And again, we mentioned standardization as a highly regulated industry in terms of the machinery, the usage, and the interpretation, both for the diseases and for the images, makes it very useful to compare across different areas and to standardize when putting inputs for AI. This is a quick example of the radiology flow within a department. So the patient comes in to the hospital, that's patient access, image generation. They get into the MRI. The MRI develops an image. The interpretation section is when the image comes in front of you. You see the lesion, for example. You recognize the pattern of the lesion, the characteristics. They give you an idea of this might be X, and then you interpret what their clinical notes provide. You provide an understanding of this might be the condition, or this might be the complication or progress, and this is then communicated to the treating team through either report or however is standard in your location. We will focus on the aspects of image generation as well as interpretation for the purposes of this, because this is where AI is mostly focused. So this is an example of image generation. We are creating extra images, essentially. We input a seed similar to essentially the static from the old televisions. This goes into a generator that creates an image, and this is compared to the ground truth image, which is a real image that was taken in an actual MRI, for example. Those two images then go into the discriminator, and the discriminator tries to tell the fake image from the real image. If it's able to identify that it is really a fake image, so it's correct, it goes back to the generator and it learns how to create a better fake image. If it is able to actually tell them apart, if it is not able to tell them apart, it goes back to the discriminator, and here the discriminator learns how to better tell apart the fake and real image. So the generator and discriminator keep competing with one another, learning from one another, and create images that are closer and closer to the real image. And therefore, we end up with a large number of images that are close to reality. And this can be beneficial for training or for conducting research on rare diseases or where we don't have enough information. And this is, of course, not a perfect situation. This is an example of image generation. This was just used the angles for a self-driving car. And as you can see, some of the stop signs are not legal authorized stop signs. They are in black, not in white. And here, this is only one parameter on color, but you can understand how this might be different for an CT or radiological image, where there are far more parameters that can go wrong with much greater consequence. So it's important to always have the human in the loop to help make sure that the information is accurate and ensure that it doesn't essentially hallucinate or get off track. We mentioned this benefit, so this can create greater training material. So this can be used for diseases that are very rare, which we don't have information on, and we're able to conduct more research on them, provide statistical significance, and get a better understanding of them. It also means in contexts where we don't have a lot of images, so for example, think in MRIs in Africa, we might be able to generate images that are closer to the local context to conduct research on them, or to train future generations on them without having to rely on external data from other regions, which might not be as useful to the local context. This is a famous study with the invisible gorilla. Initially, it was done with the ball. This is an interesting YouTube video if people are interested in seeing it. A similar study was conducted with radiologists, where they inserted the gorilla of various opacities in his lung CT, and wanted to see how many radiologists would detect it. And 83% of radiologists, even when their eyes hovered above it, did not detect it. AI performed much better. And this was an argument for the adoption of AI and that it would replace radiologists. And I think that interpretation is a bit premature and a bit maybe overly enthusiastic in defense of radiologists. You guys are not trained to identify gorillas, so it's understandable to be missed. But it also means that we need to recognize that there are certain functions which AI does do better than humans, and we can use that to our advantage. And we'll get to that a bit later on. This is another study. This was Sybil, developed by Harvard and MIT hospitals. They have been able to successfully predict that up to 94% of those who are developed lung cancer within a year, even when radiologists could not. And this is a very useful tool. We understand how likely someone is to develop cancer. We're able to take preemptive action, though describing this to the patient may be a bit difficult. we don't know, but the computer says that you're getting this, particularly since this has been a result of a black box phenomenon. We don't know what parameters are being used to recognize the pattern or predict the likelihood of lung cancer development. These two bring up a discussion where the gorilla, for example, might result in task shifting. So the mundane tasks of looking at an image and detecting, does this exist or not? So this is the simplest part of your job, might shift towards AI and relieve you for more stimulating parts of the job or approaches or for research. It also might reduce burnout if it reduces the time and exhaustion you're doing remedial or low fidelity tasks, such as just the detection. While approaches such as Sybil, where we have a prediction, but we don't know how that's happening, this could help generate hypotheses. So this could be that people go back to the data set, look and research what's happening, and develop different hypotheses for either the disease mechanism or progression mechanism. So this could result in a shift of movement of the role of radiologists, more from detection to actual active engagement with the research they're doing or with the disease progression. So further training within Africa and across the world on how to shift away from just detection and sort of the simple parts to the more cognitive and stimulating parts of our specialties will be necessary to keep up pace. And this, of course, has the potential to improve accuracy and efficiency with the AI and the physicians working in a complementary fashion to make sure both of are accurate to yield better results. This means that while AI has better patterns on quantitative measurements, so is able to provide better quantitative assessments, there will be greater emphasis on physicians with qualitative abilities. So this is the ability to emphasize with the patient, develop a patient-centered approach, as well as developing hypotheses and research questions from the data rather than just repeating tasks over and over again. And so we're expecting that the clinician role will change, and this will require a shift as Africa tries to catch up with the large parts of the world. In clinician role, what is the expectation for them to deliver? What do we train them to do? And how can we train for physicians of the future rather than just for the physicians of today? Precision health is understood to be a high resource specialty. So people have the perception that this can only occur in high income countries rather than in low resource settings. Here I argue for the value of having them in low resource settings because they have much greater return on investment, particularly in those low resource areas. The limited infrastructure is a reality, by definition, in a low resource setting, and therefore the ability to predict who's likely to get the disease, who's likely to benefit from it, allows us to target our interventions and reduce wastage. So we have a much better return on investment and we get much higher success rates, reducing wastage, which we cannot afford to do in a lot of the low resource settings. There are also higher burden of disease in a lot of low resource settings. So biologically, diseases are more likely to have been progressed. So earlier intervention creates a bigger benefit compared to the counterfactual of late progression. So late identification. So we create the greatest benefit in terms of DALYs or QALYs interventions in low resource settings. Cost of treatment, especially of late stage diseases, is much higher in low resource settings compared to the income of the individuals living in those areas. So they have the greatest economic benefit as well. And socially, there might be social stigma in career or in just society of having certain diseases, especially in the late stages, where they might not be as manageable. We also have the reality that there are fewer local origin resources, so there are fewer MRIs for us to study on and research, and this means that these are deprioritized, and as researchers work with the low-hanging fruit, they will use the readily available data sets in high-income settings, and this will continue to make the gap grow between the low and high-income areas. So we need to develop more local origin resources, and this will provide a greater benefit to the most vulnerable. While strained capacity, so as we said, limited infrastructure, higher demand, better allocation and efficiency would reduce the strain on the health systems and the economic as well as medical burden on it. So that's why I think Precision health has the greatest benefit in low resource settings and should be invested in, because however much is invested, I think it'll have a much greater return than they do in high resource settings. This is not to dismiss that there is a lot of investment required for precision health approaches, but they are more likely to reap rewards in settings such as ours. There are, however, certain challenges. So as we said, the number of MRI machines in Africa is very little. So the ability to develop a large number of data that's accurate, so it becomes more difficult. And while there are innovations happening to help create remote MRI access and mobile MRI, this still needs to be developed. The access to MRI, just having the number of MRI machines is not sufficient. We need to have people able to access as part of universal health coverage, so having this at low cost of actual value to the patient, and make sure that they are able to reach them easily. We have high concentration of MRIs in urban areas rather than reaching in rural areas. So we have a disparity where we create information on high socioeconomic groups in Africa rather than across the population. Access to data. So once data developed, it's usually very siloed. This does not go into a large data bank where people are able to research and utilize it. Data is usually not integrated, whether through electronic health records, so we are unable to connect imaging with clinical data to provide interpretations of what the data and the image might mean and how that reflects clinical data or patient experience data. So we are able to less likely be able to use it to integrate for interventions or care. There is already low representation of Africans in current data sets across the globe. And this means that the current developments or the current tools being developed are not made to work for African populations, and we can result in sort of low predictive value or low fidelity for African populations. And then there's also a limited complementary data set. So similar to the integration with clinical data, this limits our approach to be able to integrate things like radiogenomics into African settings if we are unable to integrate genomic and imaging data together to research and their interaction with one another. So these are some of the major challenges in Africa with developing precision health in the continent. Approaches to reduce those challenges and provide better precision health approaches for populations, particularly around imaging, is to promote local sources and production. So this is use of MRIs that are developed in Africa, as well as MRI images developed in Africa, as well as producing actual algorithms and approaches to precision healthcare in Africa, rather than just importing them from other areas to make sure that they're tested. Africa has the largest genetic diversity in the world, and we have a large diversity in terms of our demographics, our diseases, our burdens. Having federated data banks from across the continent working with one another, sharing data, means that we get a compounding effect with greater data points and variability to train our tools. So if you're a part of an institution, working with other institutions or nations or cities, however you'd like it, to bring your data together and benefit both, we create more than the sum parts. Mandated performance reporting for AI tools across demographics. This becomes very important, especially in imported AI tools. If they are not tested on African populations, we might be spending money, resources, and training on utilization of these AI tools, and they might not reap the benefit for our populations, and we might not have a proper monitoring and evaluation program in place to make sure to evaluate if they are working or not. So it's important that we start requiring those coming in to operate in Africa to mandate where these tools were tested, how they were tested, and how they were reported differently. So how did they perform for people of African origin, of Asian origin, and so on. And we could even go more granular and require them in particular regions, as Africa is not a monolith. We need to improve patient-centered accessibility at all stages. So just having improved precision health is not enough. We need to improve access to getting people into the MRIs, getting people to not have to go into debt to pay for these images, to make sure that this is actually usable, and that when we develop the AI tools, people are actually able to get the MRI that helps them, and then the tool can be rolled out and help them. It is important that equity be built in from the very start. So as we develop our AI tools or MRI accessibility program, that equity is a leading point, identifying what are the vulnerable populations, what are the parameters of equity we'd like to address, and develop a program for it rather than trying to add it on at the end, which is usually not very beneficial. We also need to promote algorithmic fairness. So this includes things like predictive parity or odds fairness. This approach means that we want the algorithm to be as good for different groups. So we don't want a lung cancer that is only able to predict lung cancer AI tool that is only able to predict lung cancer for men ages 30 to 45. We want an algorithm that is able to predict lung cancer as well for men, women of all age groups. And this becomes not always something we are able to achieve, but it is something we should always strive for and reduce the disparity between its function for different groups within our continent as well as between our on the global scale. This is a graph I like to share. It shows the interaction between human and AI in performance. We can see in early stages, humans and AI. Humans perform much better than AI. The current state is humans and AI perform similarly on narrow tasks. And we're predicting that in the future, AI might outperform humans, including on complex tasks that are more likely to be prevalent in medicine. But we also see that human performance increases. And if Africa wants to make the most out of its resources, including its human resources, it needs to be able to complement them between human and AI interaction to deliver the most for Africans and help advance us forward. The key takeaways: this is important to engage with AI and precision health. This is where the field is moving and we need to catch up. Radiology is very much at the forefront. So this will be you guys leading us forward. It's a multidisciplinary and sectoral approach. So this will not just happen within a radiology department. This will happen with the radiology department, the internal medicine department, and the IT department at the hospital. And then at the hospital level, they will interact with your district, with the national, and then with the continental level. And this is an approach we need to have to be truly patient-centered and to move to the forefront. It is a direction we are taking across the globe, and there is no discussion about it. So precision health will continue to be an essential part of Africa's future. It is important whether we decide if we want to fulfill that future or not. And then finally, without equity in precision health, it is just exclusion at scale. This is a term I very much resonates with me. So we need equity when developing precision health, as we don't want to leave a bigger gap and increase the disparities that already exist between us and the rest of the globe, but also within our continent. Thank you very much for listening to me. If you have any questions, please feel free to reach out to me. And thank you very much for listening.
Thank our speaker, Dr. Esham Gaffa, but he has asked Professor Ogbole to take his questions, to answer his questions on his behalf. So if you have questions, can you please indicate concerning precision medicine and AI involvement in this field of radiology? Are there questions for our speaker, or I could put his email? He's happy to answer most of your questions, almost all your questions via email. But if you have questions that we can address here, Professor Ogbole will be happy to answer them to the best of his ability. I'm not seeing anybody. I'm not seeing questions in the chat box. Neither am I seeing hands. Okay, if there are no questions, we might have to move to our last presentation for the day. By Dr. Jones Obungoloj. Is going to be talking to us about overcoming the different challenges involving the use of MRI in Africa, telling us his own experience and how he has been able to overcome them. Okay. Dr. Jones Obungoloj is a senior lecturer in biomedical science and engineering at Mbarara University of Science and Technology. He has a PhD in biomedical engineering from Pennsylvania State University, specializing in low-field MRI technology. He has been instrumental in establishing biomedical engineering in Uganda, including initiating the first program at Kayambogo University and developing the field at MOST. His doctoral research led to the creation of an infant-sized low-field MRI system for use in low-resource settings, particularly for diagnosing hydrocephalus. Dr. Obungoloj collaborates with the Pennsylvania State University and Delft University of Technology on this technology and is a member of the Uganda National Association of Medical Hospital Engineers, UNAMHE. So he's going to be talking to us about overcoming the challenges, MRI challenges in Africa. Join me as I welcome him. I will play his video shortly. He's online. He's going to be available to answer your questions. Welcome aboard, Dr. Jones.
Thank you, everyone. Welcome to the workshop.
Good evening, everyone, and good morning to those of you who are in other time zones. I am called Jones Obungoloj. I'm from Bara University of Science and Technology in Uganda, where my MRI lab is located. And I am also proud to be associated with the Smart Africa Network that is organizing this virtual workshop and conference to follow next week. So I'm here to talk about overcoming the challenges of MRI technology in Africa. And I think all of us could understand what challenges we are talking about. But before we go into these challenges, I want to tell you about Uganda, where I am located at the moment. Uganda is somewhere you can see the little red dot in Africa, eastern side of Africa. So from wherever you are, if you are to come to Uganda, you will most likely land somewhere here at the international airport in Entebbe. and take a 6-hour drive to Mbarara, where I am. And when you reach Mbarara, you will find me in this building at Mbarara University of Science and Technology, where my lab is located. And it's a relatively small university with about 6 faculties, has a student population of 5,700 students. And my faculty, which is the Faculty of Applied Sciences and Technology, which we normally call FAST, started in 2017. So now that you know about Uganda, let us go back to challenges of MRI. The challenges of MRI are many, and some of them you probably have not heard. I want to tell you this story. Sometime last year, a manager of one of the banks here contacted me and said, we have an MRI machine. We are looking to sell it. Do you have anybody who can buy it? And I was like, what is a bank doing selling MRI machines? And he was like, no, there was a client who got some loan to buy the device, and he has since failed to pay. So we have repossessed the device. And we didn't know exactly what we were dealing with, but here we are now. The bank has now deployed security to keep the machine. The machine was installed in a rented facility, so the owner of the facility expects the bank to be paying rent every month, and the bank is now stuck. And I was telling the manager that even getting somebody to take that device for free, let alone selling it, is going to be a little bit of a problem. So those are some of the challenges of MRI. But we have been in this business of MRI for a while, and we know our usual challenges of the device. Of course, there are challenges that are related to costs, and in the end, it really ends up in cost. But anyway, the cost of the device, as many of you know, is very high. The device needs good infrastructure. You need a good building, you need to shield it, you need some good connectivity. Our MRI in the hospital here was installed sometime last year, 2024. And the room which was provided for it, they had to remodel it, break doors, break pathways for delivering the device, shield the room, break walls, install a dedicated generator and something like that. So the facilities that are needed, the standard is quite high. When you come to expertise to operate and to maintain the device, is very costly. You could have your device and you make some money, it gets a small fault, and all your profit for a whole year is gone in trying to maintain and fix that little fault. So these are the usual challenges of MRI that many of us are now familiar with. It is, and to overcome these challenges involves a lot of people. We need to involve the governments, we need to involve charitable organizations, we need to involve vendors and manufacturers. Recently, I have been engaged, not really recently, for some time, I have been engaged with our government agencies on trying to find funding to support this low-field MR device that we are making. And the questions they ask are not really scientific questions. They are questions of market, they are questions of profits, they are questions of the cost of manufacturing, they are questions of... So these types of questions are a little bit strange to us. We want somebody to want to show somebody that the technology is good and it works, but the other people are interested in where you're going to sell it, who is going to buy it, how many people are they who are going to buy this device. So we need a lot of people involved in this transformation if we are to overcome some of the challenges of the MRI device. And of course, some of these, like I said, can be done by governments. If you look at the power coverage, for instance, the electricity coverage in Africa, many countries still have more than 75% of their populations without access to electricity, and these are mostly in rural areas. So you can imagine that you might never be able to take these MR devices to rural areas in the next foreseeable future. And it is only governments who can try to fix a little bit of this by extending power to people. Large companies or governments should be able to do this. So we need their involvement. In Uganda, for instance, we have the rural electrification that started some time back. They are promoting mini solar grids in rural areas to make sure that people access electricity. So some of these efforts are needed. If government gives concessions to private companies, maybe power can be extended to some of these rural areas as is needed to enable overcome some of the challenges of power. And the other challenge is capacity development. We need to develop a lot of capacity, and I am thankful to platforms such as Smart Africa Network, the ISMRM, the Camera Network, for championing the training and developing capacities in Africa. I currently have one of the trainees in my lab somewhere in Spain, in Joseba's lab, undergoing training supported by the ISMRM. So these training opportunities are needed, and this develop capacity of people that later come back to the continent to give back. And even if they don't come back to the continent, they are points of contacts that we have in the continent, wherever they are, to tap into their knowledge. Many of the people that are supporting us are of African descent, but they are based in several other countries, and they are doing quite a great work supporting the continent, especially in this MRI trainings and support that I am involved with. We need collaboration. We cannot work alone. Before we started some of these platforms, nobody knew who was doing what. But now we are brought together by the Smart Africa Network, by the Camera Network, by the ISMRM African chapter, and the Global ISMRM. So we are collaborating now. I have collaborated with quite many people, and without that collaboration, I don't think anything in my lab would have ever seen the light of day. So this formation of collaboration groups are great. That's why we are here today. It is part of the collaboration that is we are doing, and this is very beneficial for the access of MRI devices in Africa. The mentorship networks, Smart Africa has doing this. The Medical Artificial Intelligence Laboratory based in Lagos has done this a lot. The ISMRT is mentoring a lot of radiographers across the continent. The Camera Network is doing a lot of mentoring, and many other labs that I may not have mentioned here are doing a lot of mentoring of the young people, because these are the people that we think have the right mindset to overcome some of these challenges of MRI. When we bring in the young people, they are enthusiastic, and if we don't tell them that what they are trying to do, we have already tried and failed, they will probably succeed without knowing that it was even difficult to some of us. So we need to do a lot of mentoring, and of course dissemination of our work. After we have done some work, we need to disseminate. So we are again glad for platforms such as this. You can see some of the dissemination workshops that have been organized by the chapter, by the Smart Africa Network, by the Camera Network, by many other people, so that we can disseminate whatever little we have gained from the different workshops and trainings that we have attended. The issue of medical equipment financing, if we need one, like we said earlier, one of the challenges of MRI is the cost. So can somebody get financing if you are to eliminate the issue of cost, to be able to maybe buy these devices, provide some of the accessories that are needed to operate the device. But when you come to some of the countries like ours, the cost of financing is very high. Our loans here, for instance, if you get a loan from a bank, is between 22 and 25% per year in interest. And if you get from the little money lenders, that cost is 5% per month. So if you ever get a loan to start a business, you probably will sell the business to pay the loan. So the challenge of medical equipment financing is a big one across Africa. So even as we are talking about some of the little devices we are making, we still need financing to do that. And it's very difficult to go to commercial banks to get that financing in a meaningful way. But there is the other thought of saying that instead of trying to provide what the big MRI systems need, we could try to go around it. So that is the move to appropriate medical technologies or appropriate MRI, as we would call it. And there are a number of initiatives to do this. I am sorry that I have not credited this, but you could see the ISMRM, the Hyperfine, you could see EDU's system, you could see the Physio MRI in Spain, something in our lab, the Empress somewhere in Israel. So there is a move towards appropriate MRI that will leverage whatever is already existing without needing more to make the systems operate. And this comes with the value proposition that the low-field MR systems have. And the value of these systems is in the requirements that make the high-field systems inaccessible. And one of those is, of course, the footprint and portability. Many of these systems are less than 600 kilograms in weight, probably. They occupy less space. Probably if you have 2 by 2 by 2 meters, you could slot the system in. So you could easily push it between beds to do imaging. The systems are on wheels as compared to the traditional systems. I know that there are some traditional systems that are also on wheels, but if a wheel like this rolls over to your door, you probably say that is not the kind of wheels that I had ordered. So we think that there is a good reduction in the footprint of the MRI system. So this reduces the demand on infrastructure that is needed to have the systems involved. The low-field MRI systems also run on very low power requirements. Our system currently runs on less than 500 watts of power. And we think that even if we increase the gradient field strength, we probably will not go beyond 1,000 watts or something like that. So if you compare to the traditional systems, you need up to probably 9 to 10 kilowatts of power on standby to make sure that you can operate the system pretty well. Some of these systems, we are now trying to run ours on the battery system, and we think that it is possible to run it on the battery, even to carry out several other images. So we see that there is also another value there in these low-field MR systems. The installation and maintenance, many of the systems are sort of plug and play. You don't need a shielded room, you can wheel it into a building, and you can plug it into a wall. You can see me there trying to roll the Hyperfine system when we had it in our lab. And this is possible. You don't need a lot of work to be able to do that. And you can see me here a few minutes later. I am already trying to operate the system. If it was a high-field system, this installation would take months. You there and things like that. So this is another value of the low-field MR systems, that the installation and pretty much maintenance is also not as complicated as it would be in the high-field systems. If we look at the operation, for instance, the operation is relatively easy. I probably say there is not high technical need for this, which is subjective, but yes, we have been able to train the people for a few years to be able to operate these systems, and we think that the operations are relatively easy. You don't need much of the training. However, the training, we can have another discussion on the level of training that is needed to make some of these systems operational. But again, we think that it is much easier than the high-field systems. If you come to the issue of costs, while many of the systems are still in research stages, we think that these systems could be less than $100,000 in cost meaningfully. And if we can keep that cost low, we will probably realize a value of this system. However, these are currently the costs that some of us scientists and researchers talk about. When it comes to business people, it is difficult to tell what this cost will be, because then there is the shelf life cost, there is the shipping costs depending on where the system is going to be shipped from. There are regulatory requirements that require you to pay some amount to get some regulations. Those costs need to be recovered. There are costs of financing, like I said, somebody probably has borrowed money to start a factory to make this. That money needs to come back. So it's a little bit difficult to tell what costs these systems might end up with. But we still think that they can be reasonably less than $100,000. The ease of fabrication, at least for demonstration or training purposes, you can easily assemble one of these systems. Getting it to operate is another issue. It might take a lot of meticulous effort to get the system to operate. But at least you can inspire people by bringing them together. They put up a system and they can see, they might see some FID or some noise in there. This is a good PR for some of these systems. We made our system in 2023, I think, and we recently were able to acquire some of these images you see on the left. Again, with the meticulous effort of our collaborators that were camped in our lab for a number of weeks to be able to attain this. We think that we can even still make this better, these images better, when we get stronger gradient amplifiers. But you can see that we are moving towards clinical applications in these systems. The potential impact of this system, like I said earlier, that there are a number of things that limit the traditional systems from reaching the big part of our populations. We think that these low-field systems, because of their limited requirements, can reach a lot of people. We could take them to rural areas where we probably cannot even think of putting a high-field MR system. If you look at the Ugandan health system, for instance, which I think is similar to many other African countries as well, the bulk of the population are served by low-grade hospitals, for instance. Uganda is currently thinking of buying MRI machines for the regional referral hospitals, that is the red line coming down, and the national referral hospitals. But that only serves a certain percentage of the population. The other 73% of the population will probably never see a high-field MRI in their lifetime now. And so these low-field systems have potential to reach to such places. We are currently trying to work on a grant with one of our collaborators again to deploy low-field MR system in a rural hospital. And one of the hospitals we have chosen is a very rural hospital in the eastern part of the country. So if the grant goes through, this will be another demonstration that we can deploy these systems in places where you can't even start thinking of deploying a high-field system. And I think that if we work together and we do a multifaceted approach, provide the requirements that are needed for high-field systems to be accessible, but also transition to the low-field systems to cover the gap that would otherwise never be filled by the high-field systems, I think we will be working towards democratizing MRI access in Africa. And with that, I want to say thank you to you.
Excellent presentation, Professor Dr. Jones. It's
Thank
good.
you, everyone. I am available for questions. Thank you.
So I think the floor is open now for comments and questions. Please type your questions in the chat box, or you can go ahead and raise your hand and speak. I think somebody is God's favorite is clapping for you. Thank you so much.
Thank you. Thank you.
So let's have questions now. Thank you so much. So do we have questions from the floor? Please don't be shy. Go ahead and speak or just ask your questions.
Hello, good morning, sir.
Good morning. Please go ahead.
Afternoon, yeah. What is the potential of the hyperpine machine in the perfusion imaging?
Pardon? I didn't get I didn't get you well. I just had hyperfine.
Yeah, the hyperfine machine, which is a low field MRI.
Yes.
What is its potential in perfusion imaging?
Perfusion imaging and hyperfine.
Perfusion imaging. Hyperfine, I wouldn't be the right person to talk exactly about the capabilities of hyperfine, but as far as we have used it, it can do pretty much all the modalities of imaging that are available. The diffusion might not be as good as some people who have worked with high field systems would wish, but still, I think it's a very impressive system.
Yeah. Thank you very much.
Good.
Any other question?
Yeah, hello, sir. Can you hear me, sir? Good afternoon, sir.
Good afternoon.
Okay, sir, I see that you talked more about the low field MRI system, and you made mention of the fact that even though it's the results and what it can do can't be compared with that of the high field. I would like to ask if for research purposes, can the low field MRI give a very desirable result if engaged?
So the field of low field MRI is still growing. We have now been blessed with the introduction of AI almost in everything. Originally, we didn't think that we would even reach the resolutions of the images that we are reaching now without post-processing. But given the capabilities of post-processing now, lots of people are writing a number of algorithms. We think that low field systems can now give very impressive results even for research purposes. There are people now who are trying to build the systems for preclinical scanning, animal scanning. And I think the capabilities are still very high, and we have not reached really the maximum or the limits of the capabilities of low field MRI. Young people are still coming to make these systems even perform much better than we probably thought they would. So yeah, I think there's a lot of potential in low field systems.
All right, thank you very much, sir. Please, one more question. Not like a question, like a request. I was really impressed with the presentation, but I wouldn't know if I could get your email and probably discuss with you on the possibility. I don't know if you've used the low field MRI to carry out research at Bara University before, but I would like to just discuss with respect to what I'm working on if the low field MRI can be utilized. Thank you, sir.
Okay, sure. I think you will send me an email with what applications exactly you would wish to do with the low field MRI. I am just putting my email on the chat. And if I get to know your applications, I might be able to find within our networks, even if it is not possible in my lab, but within our networks, we should be able to find a place where you can apply what you need to do with the low field MR systems.
All right, thank you very much, sir. Great sir.
Good, nice.
Okay. So thank you.
Okay.
I think we've had enough for the day. So let's just say thank you, Dr. Jones, for that excellent lecture. And I would just like to appreciate everybody who has stayed on from 9 a.m. this morning to this time. I just want to appreciate you, and I'm sure you benefited a lot. And to also say that Dr. Jones is also the president of the International Society of Magnetic Resonance Imaging and the African chapter. And to also say that the African chapter is organizing a conference in Tunisia in September, from September 26th to 27th. And I'm sure most people who are interested to learn more about MRI can also participate in that conference. This workshop is an opportunity for networking, is an opportunity for mentoring, and we're going to start the full workshop. This is the virtual version of the workshop, and we're going to start the full version of the workshop next week, Wednesday, on the 23rd. If you have already registered, it's fine. If you have not registered, you can also come in and register in person at the Lagos State University Teaching Hospital. We have a roll of speakers. Some of them have already spoken. More are going to speak in the coming workshops. And I'm sure you can also visit the website to get more details. I want to appreciate everybody. And I say we're looking forward to having a wonderful time next week and building capacity and increasing MRI accessibility across Africa. I say thank you very much and have a good afternoon.
Thank you, Dr. Godwin and the Smart Africa Network for bringing us together and for organizing this. Thank you. God bless you.
Thank you so much. Yeah. Looking forward to seeing you in Lagos next week, Jones.
Sure. I will be there. Yes.
You'll be there. I'm sure you're going to get more questions and more interactions from young biomedical engineers and physicists.
Okay, sure. That would be good. That would be nice.
It would be nice if you can bring us your small MRI.
I'll bring some rings. I'll bring some rings of the system with magnets in it.
That's fine. That would be nice. Thank you so much.
Okay, sure. Nice.
Have a wonderful time. Thank you. Goodbye, everybody. Enjoy yourself. Wonderful time. So we can interact, LinkedIn and all that. Have a wonderful evening.
Thank you very much, sir.
Thank you.
Thank you everyone for joining. See you next week.
Okay, one more thing, please. The YouTube Andrew, can it be made available to us? Because I said something with my YouTube.
You can ask for anything you want through the email that you get. So I'm sure they'll be able to make that available to you. Thank you.
Thank you, sir.
Thank you. Till Monday, Prof. Till Wednesday.